Welcome back. This is the plenary session. I'm very happy to open the plenary session. My name is Evelien Dekker. I'm the chair of this committee, and the regional chair is Uri Ladabaum from Stanford University. And I'm very happy to have collaborated with him. Actually, he's done the major part of the job of creating this program for this afternoon. I think it's very well designed. It came out nice. We have good speakers. People agreed. We are very, very happy you're all here and willing to present for us. We are looking forward to that very much. We are very grateful for the sponsors to enable this occasion again, because every year it's becoming more expensive and more difficult to arrange this kind of meeting. So we are hopefully coping with that every time again. So thanks so much to all the sponsors, and you will see them on the slides. So Uri has a few slides to present on the topic that we are discussing today, and then we will hand over to the two chairs of the first session. Thank you.
Thank you, Evelien. This is my favorite gathering of the year, and it's great to work with you organizing this. I want to thank all the international attendees. We struggled whether this should be virtual, hybrid. There's no different, there's nothing better than in person. So thanks to all of you who make the effort to come here. We need you to continue coming to the American meeting. To put this session in context, this is how we conceptualized it. I think the collective group working on risk stratification and personalization is coming at this from various different ways. So we thought this would be a good conceptual framework. At one end of the spectrum, we'll hear about predicting and trying to assign a screening modality. There's some algorithm that says maybe these people are better served by colonoscopy than non-invasive testing. At the other end of the spectrum, we have a unique situation where we know that there are certain dominant genes that we're using to set a lifetime program. And that's both when to start, what the intensity is, and usually the modality is colonoscopy. Then there's the question of, do we adjust screening threshold to trigger colonoscopy in a two-step program? We'll talk about the use of past screening results to personalize what you do. This is adaptive screening using the information that the person is giving us empirically. And then what many of us hope for is that we could have something that is risk prediction based on genes, environment, potentially other things that can function like the dominant gene scenario, where we set a program based on profiling people based on their genomics, other omics, and the environment to talk about start, intensity, and modality. So with that, we have speakers who are prepared to talk to us about all of these things, and we now go to our chairpersons. Thanks to everybody.
Well, thank you all for joining us today. I'm Elena Stoffel from University of Michigan, and my colleague, Dr. Charles Kahi from Indiana University. We're delighted to welcome you to this session. We have many speakers, and each speaker has 10 minutes, and we're going to ask if you can hold your questions until the discussion section at the end. And with that, I would like to introduce our first speaker, Kevin Selby. From the University Center for Primary Care and Public Health in Lausanne, Switzerland, will be presenting on risk prediction to personalize the screening modality.
Thank you very much, and thank you very much for the invitation. So I will be presenting results of a pilot randomized controlled trial about colorectal cancer screening based on predicted risk. Actually, Yuri presented this, but what we're focusing on here is which test is used. So here we're focusing on FIT versus colonoscopy. So just in terms of personalized risk colorectal cancer screening in general, the idea is that we could optimize the use of limited resources, better balance risk and benefit for participants. But obviously, it could increase complexity, it might decrease participation, and really the impact on colorectal cancer incidence and mortality is unknown. So in Switzerland, the current practice is that average risk people are offered FIT or colonoscopy. I will be presenting Switzerland is small, but then it's divided up into many cantons. In the canton where this was conducted, right now in organized screening, it's about half-half. So about half of people do a colonoscopy and about half of people do a FIT. And then people at very high risk are excluded from the program because they are meant to have regular surveillance colonoscopy. And we felt that, so right now actually there's a problem with gastroenterologist saturation because even though the screening rates are lower than we would like, there is not enough colonoscopy capacity to meet the demand of doing colonoscopies for the whole population. So the idea is that we would use risk factors, age, sex, we'll talk about the Q cancer that we decided to use, and try to identify people based on their 15-year risk, and have people at low risk offered FIT, moderate risk offered FIT or colonoscopy, and high risk would be towards colonoscopy directly. And then people at very high risk would stay in with a surveillance colonoscopy. So this is the intervention and the control. So the control group got the information that's already sent out to participants in the program, which actually the screening program started in Switzerland about 2016. It was quite different from international norms in that there was really this idea that people would take an informed decision between FIT and colonoscopy. Since then, actually, we're gradually scaling back and making things simpler. But really, the idea was that in a table, people would look at what it was better for them between FIT and colonoscopy. Whereas now, the intervention was that this is in French, but it was based on our calculations, you are at low risk. We think that you have a 1 in 100 chance of developing cancer over the next 15 years. We recommend a FIT test. And then in there, people are still told that there's another test. There is also colonoscopy. But the idea is that they're more strongly oriented towards FIT. However, this is happening in a context where most primary care doctors in Switzerland still strongly prefer colonoscopy as the primary test. So the method is a 2-arm randomized controlled trial with 1-to-1 allocation. Only the participants were blinded, in that we were told that we were comparing 2 invitations and not the nature of it. And this was done in collaboration with the WEO canton screening program. And we also had a participative process with patient and citizen partners. So in terms of the recruitment, so the inclusion criteria were being a resident of the canton, being aged 50 to 69 years, not yet having been invited to the program. So that was a bit unfortunate, actually, as an inclusion criteria. That was a bit of an insistence from the screening program, who were quite worried that people who had already chosen one screening modality and were accustomed to that would then be told, oh, actually, the government suggests that you have this test. But because the program has been in place for several years, you'll see that that limited us to a younger age group. The exclusion criteria was there was a questionnaire about symptoms, if people had a personal history of colorectal cancer, if they had a high risk of familial syndromes, or if they were already up to date with screening. So we did a fair bit of thought about which risk calculator to use, and we ended up using the Q cancer calculator. This is the one that people might recognize from the BMJ RapidRex. It was developed in the UK using using electronic health record information. So there's no genetic information, but it's based on things that would be available in an electronic health record. We liked it because it's open source and that it has colorectal cancer as an outcome as opposed to the chance of having advanced neoplasia. And it has an area under the curve about 70%, which is comparable to the best risk calculators that we have currently. If you look at the variables, there's age, sex, smoking, alcohol consumption, family history of colorectal cancer, body mass index, and diabetes. There is not exercise, there's not diet. And then there's this personal history of several other cancers that in the derivation were found to be associated. But as someone who works in colorectal cancer, it's a bit surprising. You don't expect to ask men if they've had oral cancer before when you look at this, but that's how the score is. There is also race and ethnicity, as well as a neighborhood deprivation index in the original score. However, we were concerned that the race and ethnicity wouldn't overlap with the risk patterns in Switzerland, so we did not use that. And then there is not, the neighborhood deprivation index is not the same. So in terms of the sample we had, so we mailed out invitations to 5,636 people. We had 1,039 individual responses. So this might appear very low, 19%, but just to put in context, actually the screening, there's a lot of opportunistic screening in Switzerland. So actually the organized program has a response rate of about 22%. even though about 55% of the population is up to date with screening. We excluded certain people because of incomplete information. We actually had a lot of trouble with our consent process, unfortunately, but we learned a lot. And then we randomized 515 participants. And the thing to look at here is that the average age was 52, so which becomes important when you look at the results, because we had overwhelmingly low-risk persons. So actually one of the things that we underestimated with acute cancer is that when we did simulations without sort of the whole population profile, we thought that even though we had a younger age, it would still be relatively heterogeneous. But as you work further with acute cancer, you realize that it is overwhelmingly driven by age. Not overwhelming, but because age is an exponential function in it, if you put a threshold at 3%, until you get up to about age 60, almost everybody is classified as low risk. And then because these were people who were responding to this, it was a group of people who had a relatively high intention to be screened, so 4 out of 5, and similar between the two groups. So here are the results. So we used an outcome that we called appropriate screening. An appropriate screening, if you go back, was that if you had a risk under 3%, you did a FIT. If you were at moderate risk, which we had some people at moderate risk, there was FIT or colonoscopy, and then if you were at high risk, you were supposed to do a colonoscopy, but we didn't have any participants who were at high risk. And what you see is that more people did appropriate screening, which in this 98% low risk population means that more people did a FIT, and overall screening remained the same. And so appropriate screening update increased by 14%, and the overall screening was about 50% in both. And this was at 6 months follow-up. So, and then there's another part to this project that on top of the pilot randomized trial, we also collaborated with the MISCAN group to do modeling work to try to extend this, because this was at 6 months follow-up what test was taken. So this is work done by Luc Van Duren, who is here somewhere in the audience. And just to try to walk you through this figure, so these are outcomes of risk-based recommendations and age-based and reference strategies. So what you see on one corner, you can see FIT only, if that was the case. So compared to no screening at all, you see that you have about 160 qualities gained for about 1,250 additional colonoscopies. And then if you look at colonoscopy only on the other end, you see that you have more qualities gained, but you have far more colonoscopies. So that's if at age 50, you're recommended a colonoscopy and you do every 10-year colonoscopies. And what you see in between is that actually in the modeling, compared to the acute cancer, the effect of having an age, a specific age where you switch test modalities, performs just as well as actually is using the acute cancer. So we're still trying to think of the meaning of this result. And so basically that means that if you have a system where at age 50 you start doing your FIT, and that at a given age you just switch over automatically to colonoscopy, that performs just as well as using the full acute cancer model. So in terms of the discussion, so a response rate of only 19%, but it's relatively similar to the participation at 6 months after invitation to the screening program. Using the acute cancer calculator, pretty much everyone aged under 55 years, and actually even if you go up to 60 years, almost everybody is below this 3%. And this we confirmed. Luke did some work of plotting out the distribution in older populations, and so we confirmed this distribution with the MISCAN modeling. The modeling suggests no advantage to using the acute cancer calculator beyond these age-based recommendations. So actually we're thinking of ways of trying to improve the risk modeling by incorporating FIT scores, because you, on a population level, so an individual might change groups based on these other risk factors, but at a population level, you really don't do much better, unfortunately, based on this area under the curve of 70%. Limitations, so we did not have any high-risk participants, so we don't know the effect of telling people to do a colonoscopy, if that decreases participation. The consent required limits some generalizability, and then modeling assumptions. So our conclusions are that communicating personalized risk and recommendations increased appropriate screening and maintained overall participation. Some people might be curious because there's been several previous studies trying to use risk-based recommendations to increase screening rates, but that has generally not worked from what I've seen, and that's the same thing we had here. It is feasible to conduct clinical trials in the context of Swiss screening programs. That was actually the main goal of the pilot, was to see that. Personalized screening might safely optimize the use of colonoscopy resources and decrease the burden of screening on participants. However, there's limited benefits of a risk score over age and sex-based approach. And the next step for us are try to evaluate the impact of this with individuals at high risk of colorectal cancer, and then conduct a larger study with longer-term impact to see the impact on the detection of advanced neoplasia. Because this is one step, and then obviously the next step is also to see, does the risk score also perform well in a clinical setting? Thank you.
Thank you very much.
Thank you, Kevin. We ask you to have a seat at the table, please, for later discussion. Our next speaker is Professor Erin Simons from Flinders Medical Center, and the title of the talk is Adjusting the FIT Positivity Threshold to Select Persons for Colonoscopy. Welcome.
Thank you very much. Just putting up my declarations here. I thought I'd start off by showing you where I'm from in South Australia, where we have beaches and kangaroos and wineries, as well as a very high rate of colorectal cancer. So in our country, it is the second most common cause of cancer death. And there are a number of individuals in the community that we do have to be looking after. We need strategies to address this high mortality rate. So we've got our general population, we've got symptomatic individuals with gastrointestinal symptoms, and those who are undergoing regular surveillance colonoscopy. So a lot of our research is focusing on whether we can use fecal immunochemical tests, or FITs, in all of these groups to determine who's most likely to have a colorectal cancer. And if we can, what FIT positivity threshold should we be using? So to give you an idea of the setting that we're currently using in Australia, is we use a 2-sample OC sensor FIT in the general population, which is provided by post to people aged between 50 and 74. Now, in this FIT, we use a threshold of 20 micrograms of hemoglobin per gram of stool. And there's a number of reviews now which have shown that FIT for screening is very successful at reducing the colorectal cancer incidence, and this is by finding these bleeding adenomas early to prevent cancer from developing. And we can also see that it causes a 47% reduction in colorectal cancer mortality by allowing for early detection. Despite these benefits of FIT, in Australia, in the symptomatic and the surveillance populations, we're still using colonoscopy. Now, this does account for most of the colonoscopies that we're doing in our country, but what we see is when they come for colonoscopy, between 80 and 85% of these individuals do not have significant neoplasia found. So we do need alternative options for these groups because we do have a limited colonoscopy capacity. In the UK, we know that they're using a 1-sample FIT for the gastrointestinal symptomatic individuals. So we're interested in whether we can use this same approach for our groups in Australia. Now, in the UK, a lower threshold's used. So you can already see there's a couple of different FIT positivity thresholds being applied. So why is this FIT threshold important? Well, by using these quantitative FITs, it's possible to adjust and select the FIT positivity threshold. It's appropriate. Now, this may be based on how many cancers and advanced adenomas need to be detected, as well as minimising the number of false positives, as well as considering how many individuals are going to be sent for colonoscopy after a positive FIT. So we wondered, can one size fit all? Well, let's have a look to see what's happening around the world. And if you were in the earlier session, you would have seen Graham Young present some of the WEO survey results. And what we can see is there are a number of countries that are setting a low FIT positivity threshold of between 10 and 20 micrograms of hemoglobin. But then we also see the upper end of thresholds being set of 80 and 120 micrograms, and kind of everything in between. We also see that there's some countries that started off at a lower threshold before they increased it up to 40 and 47. And as I already mentioned, in these individuals with gastrointestinal symptoms, a low threshold of 10 micrograms of hemoglobin is applied. So with this range being seen across the world, it's clear that one size does not fit all. So we did want to see how these thresholds in our own population, this is a mixed population here, would change the outcomes. So if we apply, with some modelling here, of what we'd see after a threshold of 20 micrograms, we would see that just over 4% of individuals would need a colonoscopy, but we would pick up almost 3/4 of the cancers. If we increase this threshold to the upper level, which is seen in screening at 120 micrograms, less than 1% of individuals would need colonoscopy, but would also reduce the number of cancers being detected down to 52%. So which of these is our best option to use? Well, it really depends on the priorities and the capacity of the program. What the WEO survey showed is that those countries that are setting a higher FIT threshold for positivity, that priority was based on what they could do with colonoscopies, what their capacity was like. Whereas the countries setting the lower FIT thresholds, their main priority was picking up as many cancers as possible. So what we also see is that the FIT performance does not only depend on this positivity threshold set, but also depends on the type of cohort being studied. Now, in the general screening population, a number of reviews have shown that between 70 and 89% of cancers can be detected, depending on the positivity set. And when we combine the detection of advanced adenomas with cancers, we can pick up between 31 and 38%. Now, when we apply a one-sample FIT to our own population in the symptomatic and the surveillance individuals, what we find is that we can pick up 61% of the cancers and advanced adenomas in the symptomatic population, but only 28% in this surveillance population. Now, this kind of makes sense because these symptomatic individuals, it's likely that this is their first colonoscopy. Any lesions, any pathologies that are there are more likely to be larger and losing more blood. Whereas the surveillance individuals, they're having colonoscopies every 3 to 5 years. So anything that's growing in this interval is going to be smaller, losing less blood. So it's all making sense here. But another thing to consider is when we rule out the need for colonoscopies in these individuals is how many cancers might we be missing. Now, if we consider a one-sample FIT at 10 micrograms of haemoglobin, we can see that in these individuals, in the symptomatics, we're missing about 15% of the cancers, but we're missing about 30% in the surveillance intervals, in the surveillance colonoscopy patients. But what we can see is by applying this threshold, we could avoid 80 to 83% of the colonoscopies. But maybe to pick up more of the cancers, we can just apply a lower FIT threshold. So if we drop it down to 2 micrograms of haemoglobin, we would only be missing 5% of the cancers in the symptomatic individuals and be able to reduce the number of missed cancers down to 21% in the surveillance individuals, and we'd still be able to prevent over 50% of the colonoscopies happening. But maybe we could do even better. Maybe we could use a 2-sample FIT with a low threshold in these rule-out scenarios. So in this case, we can further drop the missed cancer rate even further down to 11% in these individuals having the surveillance colonoscopies and still prevent over 40% of the colonoscopies. Now, this is the strategy that we're actually applying at the moment in an RCT in South Australia, where individuals who are regularly undergoing these surveillance colonoscopies, if they've had a very low 2-sample FIT level, with both samples less than 2 micrograms of haemoglobin, they'll be randomised to either having on-time colonoscopy or a delayed surveillance colonoscopy. And hopefully next year we can present some of those results. But maybe we should also be considering further personalisation of FIT thresholds. Now, we heard this morning that sex is one of the contributors to differences in FIT thresholds. And you can see in this study that the haemoglobin levels consistently at each age group is lower in females compared to males. And there has been a couple of Scandinavian countries that have trialled different FIT thresholds. So in Sweden, they found by lowering the FIT threshold for women, it led to equal positivity rates. Whereas a trial in Finland showed that by lowering the FIT threshold for women, it could lead to equal colorectal cancer detection and positive predictive values. So different FIT positivity thresholds can lead to comparable performance between males and females and should definitely be explored further. But maybe we should also be considering further personalisation of the fit positivity thresholds. We could be applying clinical and genetic risk factors. But if we do, this needs to be done in a way that's accessible for all CRC screening programs to be able to easily use. So just to conclude, regarding fit positivity thresholds, we do need to consider an appropriate balance between workload, sensitivity and specificity, as well as cost effectiveness, as well as considering what population we're applying this to. Lowering the colonoscopy workloads does compromise sensitivity, especially for picking up the advanced adenomas. We do need to consider the number of fit samples being used and potentially consider lower thresholds for these rule-out strategies. So in conclusion, one size does not seem to fit all, but by using fit with an adjustable threshold, we can allow for personalisation to match the program capabilities and goals. Thank you for your time.
Thank you very much. Please join us up here, and we'd like to invite our next speaker will be Rainier Meester, and he will be speaking on using past colonoscopy screening results to adapt a personalized screening program.
Thank you very much. I wasn't aware. Oh, there's the screen. Sorry. See how this works. Okay. I have one disclosure. I combine positions in industry and academia. In preparing for this talk, I was reminded of the very first course I ever took in epidemiology, where our instructor, Albert Hoffman, distinguished between risk factors and risk indicators, where factors are from the Latin facere, to make, and indicators is from indicare, to point to. In the first category are things like smoking and the APC gene, but a lot of things we refer to as risk factors are in the second category. So age, sex, family history, and it also includes a lot of things that we wouldn't immediately think of as such, and well, screening test results are in that category too. That'll be the focus of my talk, but one more note on what I'll collectively call risk information is that it is, as you're probably aware, non-static. So it'll change over time, and we'll get regular updates of patients' risk. And in screening, that of course happens naturally with new screening test results. Now, the idea of adaptive screening, as I'll refer to it in the rest of this talk, is to account for the updates in risk information in terms of new test results. The current paradigm is to screen people every 2 years or every 1 year in case of stool testing, and only refer people to colonoscopy if the test reaches a certain threshold. Risk adaptive screening is to consider additional options given patients' prior test results. Now, I'll skip over a few slides. The idea should not be completely outlandish to you. We've been doing this for many years in surveillance colonoscopy. Depending on what is found at the baseline colonoscopy, we refer people to colonoscopy in 1, 3, 5, 7, or 10 years in the American case, but similar rules exist in other places. It is for non-colonoscopy tests that it hasn't been done or isn't been done, and this is what I'll focus on further. Now, the simple case is a qualitative test where you get just a positive or a negative result, and there's not a whole lot of information contained in that result, as well as a whole lot of possibilities of what you can do with those results. But you can still imagine that after X number of negative tests, that patients are at decreased risk compared to the risk they were at when they entered the program. And so extending the interval might be something to consider. And my expertise is in decision analytic modeling, and I've seen and done a lot of studies in this realm, but this idea, I don't think, or I haven't seen it being considered. So for anyone interested, that may be an area of, to pursue. The more interesting case, which I'll focus on for the rest of this talk, is the quantitative test. And the most well-known one is, of course, FIT, as we've seen in the last talks. Now, some of the, I'll be chauvinistic, by the way. I'll show Dutch data for the most part, but I know that there's a lot of data from other settings as well showing similar things. But this is some of the first data that I encountered on this, and it's from 2017, a Dutch pilot screening program. And as you can see, for patients with negative FIT concentrations below the cutoff in that study of 10 micrograms per gram stool, patients are clearly differentiated based on their level of measured hemoglobin. And the study showed that the risk compounds for multiple tests. So 2 tests are more informative than a single test showing a certain concentration, or more indicative of high risk. In subsequent work that I did with colleagues from the Netherlands, we put this information in risk prediction models, and we found that, if you consider this, that the majority of patients, as Aaron also found for Australia, are at decreased risk compared to the average population. But 3/4 in our case, and only 1/4 are at increased, and perhaps a fraction of that only at really high risk. And it turns out that the 3/4 that are not at increased risk are the ones that had 2 repeated measurements of no fecal hemoglobin at all in their stool test. And my colleague Esther Toos-Zoutendijk has done further research which showed that the burden to benefit of FIT in those patients, so the patients without any fecal hemoglobin versus those with some measured, differs more than 8-fold. And this is after after one round of FIT measurement, but if you look in subsequent rounds, the difference persists across screening round, more or less. So, this begs the question, should anything be done with this? And just to put this in perspective, the evidence that underpins current surveillance guidelines shows very similar differences in terms of relative rates between the groups distinguished in there. So I hope that is sort of a case to consider this further. Now, in a very general sense, what would adaptive screening look like? I think there are 2 decisions to make at every encounter between patient and physician, or after a screening result comes in. And that is, retrospectively, how do we group patients? And prospectively, how do we differentially treat those groups? So in this example, there are 3 different groups, group A being low risk, B intermediate, and C high risk. And on the right, just an example, but you could vary their screening interval, the test offered, as Kevin showed an example of, and the cutoff could be varied depending on the setting. This sounds deceivingly simple as just 2 decisions to make, but to actually analyze this or optimize this is a very complicated thing with many different options to consider. So the more practical way to address this may be to look at simple algorithms similar to what we have for colonoscopy surveillance. And an important study that is done in that direction is, again, from the Netherlands and colleagues, a randomized trial which randomized tens of thousands of participants, which I think have all been recruited, to a control arm of just a normal screening as it is done in the Netherlands, biannual FIT, and an intervention arm which divides people according to the last measured fecal hemoglobin concentration. The ones with the highest concentration are screened at 1 year, the one with intermediate level at 2 years, and then those with no measured concentration at 3 years. So this should provide great information on how this affects the detection rate of advanced neoplasia for the control arm versus the intervention arm. But perhaps even more generalizable, it will also, in a population-based screening program context, provide perspective on the feasibility and acceptability of such a program. Now, my former student, Luc van Duren, has done some work, his name came up already, looking at a slightly more general or generalizable format where patients were grouped based on risk and were offered the possibility of colonoscopy, annual FIT, biannual FIT, or triennial FIT. And he used decision analytic modeling and algorithmic optimization to to maximize the benefits for this kind of framework over a lifetime, following colonoscopy, cost-effectiveness constraints. Now, what he found was quite a messy outcome in terms of what people were offered at each age, given their risk. And this is if you let things go completely. So additional thought may be required on how we constrain these options. And again, the example of the last slide, or the trial may be one of those options, but there are other forms. Now, and he did find some additional benefit versus existing screening over the whole sort of series of options, where this slide shows just 3 examples. But that is probably an underestimate and was relying on a model of the relationship between prior fecal hemoglobin and outcomes that was at that point underdeveloped, but also requires very good data. If you can imagine that this relationship over time is something that after 2 rounds of observations is not totally clear. So there's definitely more research to be done here, and I think that approaches based on observational data are also required, where we optimize directly based on what we see in the real world, and perhaps parse this up into just a question of what is the optimal step for a given patient at this point. With that, I want to end. So adaptive personalized screening is a worthy research frontier. I hope I've convinced you. Past test results provide valuable information for adaptive programs. Now, more research is needed into how to identify optimal strategies with relevant constraints, what the clinical and economic value could be, and how to implement these across settings. I'll leave you with some words for contemplation. Progress is impossible without change. Thank you.
Thank you very much. Will you please join us at the table? Our next speaker is Dr. Ulrich Peters from Fred Hutchinson Cancer Center and University of Washington, speaking about risk prediction to prescribe a lifelong personalized screening program, including age to start and frequency.
Thank you for the invitation. Do I use this one for slide? Okay. So I want to first thank Lee Su, who is my dear colleague. All the risk prediction modeling work that I'm presenting is really her work, and she's leading it. So in terms of what we know about heritable environmental risk factor for colorectal cancer, about 35% is genetic. So the vast majority is based on environmental lifestyle risk factors. In our GECKO consortium, we have lots of resources developed, and including currently more than 150,000 participants with detailed genetic environmental lifestyle data. And given this growing resource, we thought we probably could use this and see if we can help the question of if these data can improve risk prediction. This was our first attempt, one of our first attempts, where we looked both at an environmental and genetic risk score, and we got AUCs around 0.59, 0.6. At that point, the genetic risk score only included 63 genetic variants that had been identified at that point. We've combined both of the genetic risk score and environmental risk score and asked the question, can we stratify at what age people could go for screening? And we asked the question, at what age does a person reach the average risk of a 50-year-old to develop colorectal cancer in the next 10 years, which was about 1%. And you can see individuals who have a low risk in the 10th percentile, they reach this risk threshold only at the age about 50 to 65, depending if they have family history or male or female. But those who have on the high risk in the 90th percentile, they reach this risk threshold much earlier, around 40 to 50 years old. We were quite excited about those results and thought, can we further improve this? And one reason why we felt that particularly in the genetic world we could do add contribution is because we were able to increase our sample size substantially, and we were able to identify many more genetic risk variants. Currently there are about 250 identified, but we also know that this effort, our p-value threshold is very high. We use a 5 times 10 to minus 8 to define something being significant. But we also know there's more information in this genetic data. We're testing over 1 million genetic variants. And so there are a lot of machine learning approaches have been developed to see if we can harvest these data more. And our first attempt with these machine learning models was just within our data set, including about 15,000 individuals. And we had an independent validation, which was the Kaiser Permanente in Northern California cohort, only limited non-Hispanic whites at this point. We could see that based on these machine learning approaches, we could see an improvement in the AUC compared to the known risk loci. At that point, there were over 140 identified. The next wave we did was we including also Asian, genome-wide association data from Asian populations, and also increased the sample size for non-Hispanic white individuals. And then our validation included independent studies for different racial ethnic groups. We'll see how good we do in these different racial ethnic groups. And excitingly, for the including Asian data, not only increased performance in Asian populations, but also in Hispanic populations. But we didn't see much of an improvement in the African American Black population. And that's something that's seen across all common complex diseases. It's a problem that we're trying to address. We're trying to increase sample sizes, which is really hard. We really need to do new efforts. But we're also bringing in functional genomics data to better inform which genetic variants are more likely functional, and hoping that this will improve it. I want to bring up some things to consider when we think about genetic risk factors or genetic prediction. First of all, we need to distinguish between risk stratification versus early detection, because for risk stratification, the goal is different. You know, if we use a polygenic risk score similar to family history to stratify who has a higher risk for earlier or more frequent screening, it's different than if we want to use it for early detection, which is really a biomarker that we need to, you know, it has to be much higher sensitivity and specificity measured multiple times. The polygenic risk score only needs to be measured once. It could be measured at birth if we want. It can be used for multiple diseases. It can be living in an electronic health record, particularly in HMOs. Where it could not only help to predict colorectal cancer risk, but all any other cancers, cardiovascular diseases, when somebody should start for lipids treatment, and so forth. And it's extremely cheap. A polygenic risk score, GWAS costs probably $20 the array. So that's something to consider for the future. Other things that we're excited about, you know, you could think, you know, why are we not just using family history? They're both genetic. They're, you know, it's easier. Surely, we can use family history is important, and but there's 80% of the population doesn't have a family history, and then our PRS AUC is about the best is now 0.64. It's not fair. That's why I'm putting family history in gray color, saying that it's 0.54 for a dichotomous outcome, like a dichotomous predictor like family history. AUC doesn't work well. That's at least in I see some people don't think that's in our paper, we come to 5.4, but it really, I would keep it with a grain of salt. And then family history explains only 3% of the variation of our polygenic risk score, and the polygenic risk score explains only 10% of the variation of family history. So they're really independently predicting colorectal cancer risk, and together will contribute more prediction. Furthermore, the polygenic risk score not only predicts colorectal cancer, but also advanced adenomas, not as well, but the AUC is about 0.61 compared to colorectal cancer, which is 0.64. And then we are predicting better in early onset colorectal cancer than late onset colorectal cancer, and that's particularly in those with a negative family history, which is particularly important because those individuals with positive family history will go for colorectal cancer screening anyhow earlier. So if we can, within the young population, identify those with high risk, that would be beneficial. And here, for instance, we see individuals comparing the first to the fourth quartile, we get an odds ratio around 4. I want to point out there are many other ongoing trials, ongoing testing for other cancers using polygenic risk scores. There's a Wisdom trial that is testing the effectiveness of PRS and other factors for breast cancer. And excitingly, the results apparently is supposed to come out next year. This is something to look out for. has an equivalent trial for breast cancer in Europe as well going on. The UK is doing a really large study for 5 million volunteers where they use polygenic risk scores and AI for early detection for many different outcomes. And then eMERGE is doing currently a study of about 25,000 individuals where they do genetic-guided interventions for many common complex diseases, including prostate and breast cancer. And there's a strong commercial potential for polygenic risk scores. We think there's a lot of more questions to be answered, but at the same time, companies starting to include polygenic risk scores. For instance, Myriad is including the polygenic risk score for risk prediction currently for breast cancer. I want to end with describing some ongoing future directions. We're currently developing a web tool where any individual has done their genetic testing at 23andMe, Answer.com, and so forth. There are apparently 1 in 5 in the United States has done this testing. They can upload their data to our web tool, answer questions about their lifestyle, environmental risk factors, and then we give them an individualized risk score back. This hopefully will launch next in the end of the year. As I said, we're trying to improve the risk prediction in diverse population. We are currently also assessing if we can use the polygenic risk score in surveillance setting. And I encourage you to invite Jeff Lee next year to present. He is the lead of this effort. And the reviewers were really excited about this project. They gave us the first percentile for this grant. We're working closely with Iris Landstrup-Fogart for cost-effectiveness analysis for all this. And we're currently developing a pragmatic trial to see if genetic guiding can improve screening uptake together with Larissa White in the Kaiser Permanente, Colorado. And then in the future directions, we're also thinking about combining polygenic risk score, it's a continuous value, with other continuous tests like FIT test or any blood and stool test. We're always open for collaboration. If you think we could be any helpful, we're very happy to collaborate. We make all our data publicly available. All our polygenic risk scores are available. Anybody who has genetic data can use our data. They're all out there. With that, I will finish. If you come to the Northwest, visit Mount Rainier.
Thank you very much. Now I'd like to invite our last presenter of the session, Dr. Swati Patel from University of Colorado will be presenting on updates in hereditary colorectal cancer syndromes.
Right. Thank you very much. Good afternoon, everyone. Thanks to Evelyn and Yuri for the invitation to speak today. This is obviously a vast topic, updates in hereditary syndromes. So really what I will be focusing on is, which one do I press? This one. Oh, yes, the big green one. Really our internationally diverse and I think evolving approach to hereditary risk assessment. So these are my disclosures, no relevance to the topic of discussion today. Many have seen this depiction, and it can really apply to any solid organ cancer, of course colorectal cancer, or we have for a long time thought that about 10% of all colon cancers have some defined hereditary predisposition. And historically, we codified these into very simple categories. Polyposis syndromes, further categorized by histology subtype, and non-polyposis syndromes, which predominantly were Lynch syndrome. We, of course, know that the story is far more complex than this. This was a very important publication out of Dana-Farber, wherein all patients with colorectal cancer underwent multi-gene panel germline genetic testing, and indeed 10% had a pathogenic germline variant. But we had some very interesting results where individuals had our expected germline variants, such as Lynch syndrome, polyposis, but then also variants in high penetrance non-colorectal genes, such as BRCA1 and 2. So indeed, our understanding of polyposis and non-polyposis syndromes are expanding. And as we do more and more multi-gene panel testing, the patients we care for at high risk also include those with hereditary predispositions to other digestive cancers, gastric cancer, small bowel cancer, pancreatic cancer. And to make matters even more complex, these phenotypes overlap. As I showed you, individuals with colorectal cancer with BRCA1 and 2 variants and referrals that many of us clinically are taking care of that look like hereditary breast ovarian but are found to have typically or historically thought of as colorectal syndromes. Unfortunately, hereditary syndromes are grossly underrecognized. Now, I think we're doing better than this modeling study that Heather Hampel published in 2011, but still the vast majority of individuals with Lynch syndrome, for example, in the United States, are unaware of their diagnosis. Our current approach really relies on a personal or a family history of cancer. And we know that tumor-based screening for at least the most common hereditary syndrome, Lynch syndrome, has very high sensitivity for picking up individuals with Lynch syndrome, and we can take advantage of deficient mismatch repair to identify those who may have Lynch. This is not so simple, though. It requires substantial resources, personnel, and infrastructure to navigate individuals from those who collect tissue, colonoscopists, surgeons, through all the pathologic steps, and ultimately to navigating patients to the appropriate genomic services that they need. And all of this we need to do in a timely enough fashion that it can impact potential treatment decisions, like approach to surgery. There are certainly settings where this has been protocolized very nicely, but it's a very significant challenge for a lot of settings to do this in a timely fashion. So there's been sort of a move towards perhaps going directly to the germline to identify these individuals that may have a hereditary predisposition. In addition to the study out of Dana-Farber that I showed you, out of 51 Ohio hospitals, providing multi-gene panel testing to every patient diagnosed with colon cancer under the age of 50 found a yield for germline genetic testing of about 16%. And so many centers and many settings are indeed thinking about going directly to the germline. So what is the international approach to hereditary risk assessment? Certainly not a formal survey, but in querying some of my friends and colleagues around the world, many of who are here, there are some consistencies, but there are also some very interesting differences. So across the board, most settings really support screening every single colon cancer tumor for Lynch syndrome, the most common hereditary syndrome, via tumor-based screening. There are some settings in which there's an age cutoff, though that's not as common. And across the board, most agree that those with deficient mismatch repair on tumor-based screening should be offered germline genetic testing. There's also an increasing movement towards offering germline genetic testing to all individuals under a certain age threshold because of the study out of Ohio State, as well as many other studies that are showing similar results. And in 2022, in the United States, the National Comprehensive Cancer Network actually went even a step further to actually consider germline genetic testing in all patients with colorectal cancer. We know that removal of advanced polyps prevents cancer. So what about hereditary risk assessment in those with advanced polyps? Is this a potential missed opportunity? Well, up until this point, this tumor-based screening approach has been a bit disappointing, with sensitivity of doing immunohistochemistry on advanced polyps of only about 70%. Now, that improves a little bit in older patients, in individuals with large polyps or those with high-grade dysplasia or villus architecture, but still, this system of tumor-based screening requires the same personnel, infrastructure, and resources that we aren't even doing necessarily very well across the board for cancer. So what about direct germline testing? When we look at the guidelines around the world, there's a highly variable approach in those with advanced adenomas, with many centers not really having a comment, others sort of indicating that you could consider tumor-based screening if there's no tumor tissue available or no other alternative. And then some who consider offering multi-gene panel germline genetic testing in early age onset advanced adenoma patients. The data on that approach is quite limited. Retrospective series, some studies that are fraught with ascertainment bias, and then understandably you can see that the rate of pathogenic variance because of the heterogeneity in these studies is highly varied, from 1 to almost 20%. So that's really the question that our group aimed to answer, and some initial data that I'll show you today. And we have an oral presentation on Monday, which I encourage you to come to if you're more interested. But we aim to assess the yield of multi-gene panel testing in those with advanced adenomas. This was a cohort study that we recruited individuals who had colonoscopy with an advanced adenoma between 2011 and 2024 from a statewide health system in Colorado. And we excluded those with an established hereditary syndrome, inflammatory bowel disease, a personal history of colorectal cancer, or if they've already had multi-gene panel testing. All participants, we collected detailed demographic information, clinical data, pathology data, and all these individuals were offered genetic counseling and multi-gene panel germline genetic testing with a widely available commercial panel. By convention, we defined advanced adenomas as lesions over a centimeter with the presence of high-grade dysplasia or villus architecture. We used the American College of Medical Genetics definitions of variant classification. And taking kind of cue from the National Comprehensive Cancer Network, defined clinically actionable variants as variants that would change clinical management. All variants we looked up last month to assess for reclassification or conflicting classifications. We screened over 3,600 individuals who had colonoscopy. Over this time period, the vast majority who were excluded because they didn't have an advanced polyp, and ultimately completed germline genetic testing in 191 individuals. When comparing those who were eligible and enrolled versus those who didn't, those in our cohort tended to be female. They also had a higher proportion of villus histology polyps and polyps with high-grade dysplasia. You can see the characteristics of our cohort here. I'll just point out that it's skewed towards a younger population. Those under the age of 50 comprised 48% of the individuals in our study. More likely to be female, predominantly white population, though almost 9% were of Hispanic or Latino origin. And what I'd like to point out is the vast majority did not really have any family history. So many who did not have enough family history to even calculate a PREM5 score, and only about 14% who met current NCCN criteria for genetic testing. In terms of the procedure indications, you can see sort of was across the board in terms of screening, surveillance, or diagnostic procedures, the distribution of lesions in the right colon, left colon, and rectum. And I'll point out that about 60% of the polyps that individuals had in this cohort had villus architecture, and about 26% had high-grade dysplasia. So what did we find? Well, we found that 15.6% of individuals with advanced adenomas had a pathogenic or likely pathogenic variant in a gene associated with cancer risk. When we break this down a little bit further, about a quarter were in what we consider high penetrance genes, so mismatch repair genes, BRCA1, P10. Another 40% were in moderate penetrance genes, and then the remaining were in either recessive conditions or low-risk alleles that really aren't associated with any change in clinical management. And so we can conclude that in our cohort, about 10% had a clinically actionable variant. And interestingly, only 23% actually met criteria for germline genetic testing. So how does this really fit into what we understand about germline variants? Well, these are studies on germline genetic testing in those with colorectal cancer, and I showed you the paper from Matt Yerglin out of Dana-Farber. In addition, this paper published in CGH a few years ago that used a panel very similar to this one that we used in our study, showed that there was about a 15% rate of pathogenic variants in those with colorectal cancer. When we add our cohort to this, the results actually look quite similar, with, again, the same overall rate of pathogenic variants and a similar rate of moderate penetrance variants, about 6.25%, and slightly lower in terms of the high penetrance genes. So I think there's a lot to discuss about this data, and we will reveal a lot more about the factors associated with pathogenic variants, some of the interesting pedigrees associated with the variants that we found. But at least for today, wanted to share this discussion that as we continue our efforts in improving tumor-based screening programs and maybe even going towards the germline directly in those with cancer, and consider more provocative approaches such as population-based screening. And there's a great abstract that's going to be presented by Faye Castrinos' group at the GI Oncology Plenary at this meeting. I think another part of this conversation is to leverage what we do as colonoscopists in removing advanced adenomas and not miss the opportunity for hereditary risk assessment in our patients with advanced colorectal polyps. So great science. This is not sort of the focus of this WEO meeting, of course, but if you're interested in hereditary syndromes, poster session tomorrow, oral sessions both on Sunday and Monday. And if this is your cup of tea, I encourage everybody to learn more about the CGA meeting in November.
Thank you, Swati. We'd like to invite anyone with questions to come up to the microphones, please.
Samir, go ahead.
About 20, but I think I'll start with maybe the one that I think might be the most important. It feels like we've spent a lot of time in the last 20 years coming up with risk prediction models, and some of them look pretty good, but almost none have made it to practice. And I guess I'm curious what any of you are doing to put that first, because I think some of how this all goes is really what's going to be acceptable to patients. Like, for example, will they be open to, having serial fits measured and being explained that we're looking at how their, hemoglobin levels are changing? What's going to really help us get to something where practically we could put it in the clinic? So I'm just curious what you all think about that.
I'll start off. We've actually, in our surveillance population, we've actually done some surveys, and the symptomatic population, surveys to see how they would feel about using a FIT to decide their need for colonoscopy. And the majority say, no, I'm not happy with that, I would want a colonoscopy. And then we ask them, how about if it was the specialist that gave that recommendation, would you trust that? And I think 80% were like, yes, I'd trust the specialist, but not the scientist. So I think it shows the importance of including the physicians in any future recommendations, as well as informing the consumers appropriately for what the risks might be.
Just to go across cancer screening and think about cervical cancer screening. Cervical cancer screening, I'm not sure if people are familiar with how it's evolved over the years, but it's been, from what I've seen in practice, it's been slow. A lot of people over-test it for a long time, but gradually people are spacing out to 3 years to 5 years. The algorithms are a bit more complex, but I think that over time you see. So I think that if there's convincing clinical data that we can safely space people out, I don't think it's tomorrow, but I think that if professional organizations are suggesting it, I think that it can change practice.
I probably could add for the genetic side, I see that great potential because it is so adaptable to many common complex diseases. And once it's set in the system, I think it has the biggest potential to be a risk stratifier. But we really need to do more work. I mean, efforts like eMERGE are really helping to see, in multiple common complex diseases, how it could be implemented. And I'm expecting in United States, in US, the HMOs will be the first ones, the best places for that to be implemented. In Europe, every system is different, but there probably is also bigger adaptability. And here in the United States, we have the problem that nobody wants to reduce screening because of HEDAS measurements, so that's always against us here.
Please go ahead.
Okay. Thank you, Manon Spaner from the Netherlands. Actually, in line with what Samir is asking, I had a question specifically for the surveillance for Erin. Especially in the symptomatic patients. I don't know if it were those symptomatic patients who are suspicious of colorectal cancer or that it also may be symptomatic patient for IBD. I wondered how reassured were the patients when they had a negative fit and they still had symptoms. Can you still convince them not for going for a colonoscopy?
We haven't tried that yet. At the moment, we're only collecting the data when they're all having colonoscopy. But yeah, based on our surveys, they will want the colonoscopy anyway. So it's going to take some, careful thought in how we actually bring about change in policy for that group. But we see it being done in the UK for the symptomatic individuals. I'd recommend probably ongoing fits for that group to keep an eye on the hemoglobin levels specifically.
Rodrigo, go ahead.
Thank you. Rodrigo Jover from Spain. I have a question to Swati. Very provocative results. Very congratulations. I have two questions. How do you explain this discrepancy between colorectal cancer and advanced adenoma? You show the same number of pathogenic mutation in people with advanced adenomas. And the other question is, I missed the data. How many of them were related with cancer, colorectal cancer-related genes? How many of these mutations?
That's a great question. So I'll start with the second question. Out of the quarter of patients who had a high penetrance variant, so that was 8% of the total population, 3.5% were in colorectal genes. So it was mismatch repair genes and P10 were the pathogenic variants found. And then I think we all recognize that the category of advanced adenomas, even though we define them as greater than a centimeter, villus architecture, high-grade dysplasia, is highly heterogeneous. And I, will be the first to say that there's probably, quite a bit of bias in the population that we recruited. They tended to be skewed younger than some of the other studies where all patients with colorectal cancer, for instance, were recruited, and so it's probably a risk-saturated population just by nature of the people who consented to participate. We tried to overcome that by systematically screening every patient who had a colonoscopy and inviting all of them to participate if they had an advanced adenoma. But as you can see from that consort diagram, there was over 2,000 people almost that were eligible, and we only ended up completing testing in almost 200.
Thank you.
I think we have time for one more question. Asma, go ahead.
I have a question for Erin. Erin, when you modeled lowering the fit threshold for individuals undergoing surveillance, did the results vary by low risk or high risk adenomas for surveillance, or can you look at those two groups separately?
For this is very preliminary analysis, and I haven't divided it into the pathology types, but certainly there are going to be some differences seen. The large adenomas are the ones where we do generally see the high hemoglobin levels. The high risk sessile serrated lesions, we see no hemoglobin levels pretty much. And so, when I get home, that's an excellent idea to compare what adenoma subtypes are being seen in the surveillance group versus the symptomatic groups, but I haven't done that one yet.
And a quick question for Swati. In patients with advanced adenomas with mutations, what would you compare it to? Do you have a cohort where nothing was found on colonoscopy? And if you were to do that, what would be the frequency of incidentally found genetic mutations?
That's a good question. So we have not done that in our group, but there are studies now coming out on population-based germline genetic testing, and that's a really, really important point. This was really a clinical question that I had, scoping these patients at young age with advanced adenomas. Are we missing hereditary syndromes? And so it's really not a comment on pathogenicity or etiology. What I will say, we had an MLH1, MSH2, and PMS2 patient, and then we went back to our pathologist and asked them to do immunohistochemistry. And there was absence of proteins on the MSH2 patient and the PMS2 patient, but not the MLH1 patient. And that was the one patient that actually met genetic testing criteria. And so, I think that just speaks to the imperfect sensitivity of IHC, not necessarily that the germline variant wasn't consistent with his family and his personal history, but a lot of those other variants, I think it's a point very well taken, are likely, population-based findings, particularly when there's no family history to correlate with that.
Thank you very much for an outstanding session, and congratulations to all the speakers for outstanding and provocative talks. I'd like to invite Drs. Chekmedian and Regula to kick off the next session. Thank you.
So this session is about the quality assurance in screening. My name is Jarosław Regula from Poland, together with Azadou Chekmedian. We will chair this session, and I have a great pleasure to introduce the first speaker, Graham Young from Australia, Quality Assurance with FIT. The floor is yours.
Graham, as you come up, one quick word. Thank you for coming all this way. It's great to have you back. This is for you.
If only it were true. Actually, this is when you usually thank the speakers for asking you to speak on this topic, but this, I can tell you, in my career, this is the hardest talk I've ever had to do. Quality assurance with FIT, considering the multi-step pathway and screening from subject performance right through to program implementation. I'm grateful to a few colleagues who I won't name who've given me some comments to make as we go through this subject, and my disclosures are listed there at the bottom. But in two-step screening, especially where you use a non-invasive test to select who gets colonoscopy, there are three sequential phases, each of which has its own quality considerations when we're considering the use of FIT: the pre-analytical, the analytical, and the post-analytical phases. The FIT result and how it's configured is crucial, as it identifies who undergoes follow-up colonoscopy and therefore whether or not you're detecting the lesions that you're interested in. Now, some years ago, the expert working group on FIT identified 47 different FIT systems available on the market, comprising both qualitative simple tests and quantitative quite complex laboratory tests. In fact, the 5 most used in population-based screening are automated analyzer systems that are now used in high-throughput laboratories. They include OC Sensor, the Alfreezer tests, HM-JAC, FOB CenterFit, and the Polymedco test. The purpose today is not to explore any of the individual tests, but to take you through the quality issues for these in general. In an important publication, which we'll show the reference for in a moment, there's a number of considerations in what we call the pre-analytic phase. Firstly, there's the issues about the collection device, which in summary means it must be a well-devised device that carefully meters the stool amount that goes into it. In terms of sampling the feces, it's important that sampling is easy, it's error-free, it's consistent with population customs and norms, and there's very good instructions. And then in terms of return to the laboratory, the logistics must be straightforward, and it's very important that the stool sample is kept stable. So the major quality issues that come from the pre-analytic phase, and of course I'm skimming over a complex topic here, is firstly the participation rate, which is the timely return of correctly sampled stool. And secondly, the test failures. In other words, the tests that have come to the laboratory but aren't suitable for testing. And there is the reference that refers to this sort of position, this process here. I would remind you that without participation, without correct participation and return, detection by FIT will fail in the screening process. Now, quickly, I want to go through a couple of variables that are really important in the pre-analytical phase variable. Trials that I don't have time to show you show that FIT-dependent participation rates can depend on the sampling condition and method and on the adequacy of instructions. We also know that it's important to follow proper sampling procedure. And if I show you the results of a study that has been recently done in Adelaide, you'll see from this graph, you'll see the percent of samples that are positive when testing faeces that had been spiked to a relatively low concentration of 10 micrograms per gram of haemoglobin. And if you look at the sample devices below that have not been correctly loaded, you will see that the positivity rate drops quite significantly. One of the other points that's really quite crucial in this pre-analytical phase is to note that haemoglobin is subject to degradation, and buffers for available tests vary in their ability to maintain stability. The graph on the right from Australian data, which was really produced quite some years ago, shows that the positivity rates shown by the bars are actually lowest in the higher temperature months, shown by the red line. In fact, a 1 degree increase in temperature decreases the positivity rate by 1.7%, depending on the level of haemoglobin that is there. So here's another quality issue, of course, because timely return using a buffer that's got stabilising agents is quite crucial. So let's move to the analytic phase and the laboratory standards. And as I mentioned this morning, this is the sort of area that makes the eyes of gastroenterologists water, because we really don't care, you know, it comes out of the lab. But quality requires, you know, 4 important things. Firstly, precision and trueness. It requires linearity, which is really the measurement range when you're looking at a graph of expected value versus measurement value, so it's got to be on a fairly straight line. And then there's the detection limits. Firstly, of quantitation, because any value below this is not accurate. There's the limit of detection, where you need to be able to reliably detect it. And then there's the limit of blank, where actually the test is telling you there's something there when there actually isn't anything there. So these values are really quite important in the laboratory setting. And the recent expert working group on new test evaluation made the following point. The analytical performance of any new test, and that includes FIT, must be formally documented according to the relevant standards, such as the international clinical and laboratory standards, or the quality assurance requirements, or system requirements in the USA. So every country has a strong set of standards. And therefore, the ideal fecal immunochemical test for a population-based organised screening program that is running high-volume automated tests has really 6 elements to it. The first is reliable reading of participant identity. The second is high capacity of automated sampling and assay. The third is to provide accurate, reliable and reproducible results. And note that when we're getting to low haemoglobin levels that we were talking about this morning, FIT tests are questionable at those really low levels. Quality assurance and quality control programs. There must be a policy for repeat sample collection if the sample is unsatisfactory. And I can tell you from our recent survey, recently a number of programs around the world are actually not requiring that. But finally, and really the most important thing, is that the reporting of the result from the laboratory must be in a manner that's applicable to the actual program. The chosen positivity threshold for the FIT, and Erin has already touched on that today, is crucial to achieving a program's goals. So the third bit is really after the analytical phase. How do we move forward? The first thing to understand is that haemoglobin analyzers determine the haemoglobin concentration in the buffer in the sampling device. The result is dependent on the amount of faeces collected and the buffer volume. And if you look at the 2 sample devices there, you'll see they're differing buffer volumes, they're different systems, things are going to be different. So the reported haemoglobin concentration in that sample buffer is not transferable between tests if you're just giving the direct measurement. It's valid only for that particular system. There is no international reference standard for material for this purpose. In other words, there's no central resource of poo with haemoglobin in it to send around the world for labs to check their accuracy actually against. So the expert working group and FIT has recommended that we move towards a harmonisation by converting the units of concentration from the concentration in the buffer to the micrograms of haemoglobin per gram of faeces, and you've heard these mentioned. It's actually easily done. This is achieved by correcting for the amount of stool collected and its dilution in the buffer. And the major FIT companies providing these high throughput screening tests are cooperating in really now making it possible. It was hoped that this will allow us to directly consider different fit tests and therefore assume that if they're measuring the haemoglobin at the same level, that we'll get the same clinical accuracy. That was the question. But we're already seeing results from work in Taiwan and Germany and elsewhere that show that despite this harmonisation process, you can't guarantee equivalent accuracy between tests, even when they're reporting units at this harmonisation sort of level. Now, the next issue in terms of moving forward into practice is the regulatory frameworks and marketing, and this is a very simple set of statements on a very complex area. The point is that just because a test gets formal documentation of analytic quality, it does not ensure that it will meet program goals. So regulatory frameworks address a test's utility, which is a word that's often used there, which really just means accuracy, including specificity and so on, when used according to a stipulated positivity threshold. And so one of the people I asked for comments on this from industry said that regulatory bodies provide a framework for judging a test's utility based on manufacturers' documented studies on accuracy, but they also have to have a disclaimer about the consequences of a test's imprecision. In other words, nothing is stated there about whether this test is going to fit a program. If we move to the marketing programs that result from the early phases of evaluation of the test, these typically expound on the results of closely monitored controlled clinical trials that report test accuracy against a set positivity threshold in a particular study context in a particular population. They actually report the threshold for positivity, and in some circumstances that must be predetermined before these processes are put in place. And they choose a threshold to report the results. We'll come back to them just in a minute. But just because regulatory frameworks and clinical studies document test accuracy at a given threshold, it does not ensure that it will meet a program's goal at that particular positivity threshold in the context in which you're working. Erin Simons has already mentioned to you previously, and I'm not going to go over this, that in fitting fit to the program goals, the considerations really are the workload required, the sensitivity that you want to achieve, or the middle ground, which many programs actually use, that balances the sensitivity with the workloads. And so what the whole point there is to adjust the positivity threshold so that we can actually meet the program goals. And Erin has shown you this graph, or a version of this graph, and how this can be applied. It's a major recommendation from the new test evaluation work group from this body that any new non-invasive test that's being developed must provide for us an adjustable threshold so that we can ensure that it's going to meet program goals. And just to prove to you how important this is, we've just completed well, not quite completed, but we've done the first phase of a survey of the positivity thresholds in use around the world. A very wide range of thresholds are in use. The most common threshold of 20 relates to a number of the countries there, but you'll see that about a third of countries, and it doesn't quite show in this table, but about a third in countries use cutoffs below that, and about a third use cutoffs significantly above that, ranging way above 20, the common one up to 120. So therefore, and the reasons that people are using these thresholds is they need tests with quality that allow them to adjust the thresholds. The only way you can actually work out what threshold works for you in your population is you have to do pilot studies in a population that you monitor to see if the test chosen and the threshold chosen is going to meet your program goals. So in conclusion, as I said, this is really not an easy topic, and there's so much to it in terms of quality for fit. In the pre-analytic phase, the participation rate involving timely return of adequate sampled stool is crucial. In the analytic phase, adherent to relevant laboratory and regulatory standards with ongoing accountability is very important. But in considering program implementation, note that initial clinical studies and stated analytical characteristics, even with the harmonisation units, might not identify the best positivity threshold for your program. And that meeting program goals requires identification of the positivity threshold that suits the program goals, together with ongoing monitoring of its suitability. You can only achieve this if you conduct formal pilot studies with the test that you think is right at the thresholds that you think it might be the right one before you really know how you want to implement the test in the population. Thank you very much.
Join us, Dr. Young. Our next speaker needs no introduction. Dr. Douglas Rex. He's the lighthouse in colonoscopy worldwide. Thank you, Dr. Rex.
Doug, there are other Dougs, but there's nobody with his name.
Oh my gosh. Goodness. Jeez. I think we have the point now. Thank you. That's fun. Thank you very much. Hi, everybody. I haven't been to this meeting for a long time. The ASGE always says it's a governing board meeting today, so it's my first time in a number of years, and I'm glad to be back. It's always been such a great meeting. Today's my last day on the ASGE board, so I hope I'll be back more. I was asked to talk about the history and perspective of the colonoscopy quality movement in from North America. And I'm hesitant to do that for Canada or Mexico because obviously there are different approaches, as we all know. And particularly Canadian investigators have made enormous contributions to our understanding of quality in colonoscopy. And I'm not qualified to really discuss their perspective. So I'm going to talk about the U.S. The U.S. is, of course, different with regard to screening. We don't have any national organized screening program. There is a lot of regional and within-region variation in healthcare expenditure and resources for colonoscopies. So consequently, there's a lot of variation in the use of FIT. Of course, we have organized screening, the best known example being Kaiser. But we have the Veterans Administration program and other programs are getting into organized screening, but much of our screening is still done in the opportunistic setting. Particularly in the opportunistic setting, we've seen a big increase in the use of multi-target stool DNA. And I know it's not used much outside the United States, but primary care physicians in the US in the opportunistic setting like the fact that it only needs to be done every 3 years. And the way the company runs the program creates some conveniences for them. But colonoscopy is still very widely used. However, we have no national mandate or legal requirement to measure quality in colonoscopy. We have registries that have several thousand gastroenterologists participating really voluntarily in the program. So there are some financial incentives, but they really only apply to a small percentage of practicing endoscopists, and they don't really have, they're not very well incentivized. So the cost of measuring colonoscopy quality is really borne by practices, and because there's no mandate, a lot of people still don't do it. In general, we think gastroenterologists are doing it more than other specialists in the United States, and of course we have evidence that colonoscopy quality on average is better in GI docs than in other specialties. So from a historical perspective, I just put what I thought were sort of a few key landmarks. First of all, we found out that missing occurs was a surprise to many people more than 30 years ago from a tandem study. And then our own tandem study in 1997 showed also that missing varied, and some people missed a lot more than others. So the U.S. Multi-Society Task Force, which is really just the GI societies now, in 2002 proposed this concept of the adenoma detection rate based on very limited evidence with a minimum target of 20% in a mixed gender patient population and a withdrawal time of 6 to 10 minutes. That came from 2 endoscopists in our own tandem study who had the best detection rates and who had average withdrawal times in normal colons of about 8 minutes. 2006, a group of private practitioners in Rockford, Illinois showed that there was a very tight correlation between the withdrawal time and the adenoma detection rate, and it looked like 6 minutes created a good separation. So in response to that, the ACG-ASG task force, which somehow extracted this process from the Multi-Society Task Force, said that the withdrawal time should be at least 6 minutes. I think that was a little bit of a setback in the United States because it immediately was assumed that a 6-minute withdrawal time could be a surrogate for measuring detection. And then the measure was changed. It originally was not proposed as a screening measure, but it was changed to a screening measure because, in fact, we had extracted this 20% target from screening studies. So it was felt that we should measure it in screening patients. The GI Quick registry then was established in 2009, and then came the validation studies, which I think were critical. The Polish study by Kaminsky, and then Doug Corley's study, which had many more post-colonoscopy cancers in it, and was the immediate cause of the same task force in 2015, increasing the recommended threshold to 25%. I think another Polish study in 2017 was very important because it showed that with a program, a multi-element program of improving detection, that doctors who were not so good at protecting people from post-colonoscopy cancer got better at it as their ADRs improved. And then the concept of aspirational ADR, which we now talk about these thresholds as being minimum levels of performance, but those who have levels above that should try to reach the highest levels. I think, again, that the Kaiser Group in 2022 showing that protection, this relationship between ADR and protection, continued to rise with very high ADRs was important. And then this recent group of studies showing that there's a set of doctors that have a high ADR, but they have a low SSLDR or some measure of serrated detection, and that also adds to interval cancers. And then we've recently seen some data that adenomas per colonoscopy is perhaps more informative than the adenoma detection rate. So the third version of the ACG ASGE guideline will be coming out in about a month, and I have permission. It's been accepted for publication, but I have permission to discuss the paper here to give you a little sense of the direction that the U.S. will go with regard to recommendations. And I think the biggest addition is that of an SSL-DR detection rate. So this is the ACG ASG colon group for writing recommendations, and a number of the experts in quality and colonoscopy are here with us today, and we also had some IBD experts because there are IBD indicators. In 2015, we introduced this idea of priority quality indicators that we think everybody should measure, and we've changed that a bit from 3 to 4. So the ADR, the definition has been modified, which I'll show you in a minute. The new target will be 35%. The target that we're going to start with for SSL detection is 6%. And then with regard to adherence to intervals, 90%, which is the same recommendation as before. And then we've added adequate bowel preparation in outpatient colonoscopies. We previously, from the MSTF, had a recommendation of 85%, but we've raised that to 90%, which is the same that the ESGE has had for some time. We're going to drop the cecal intubation rate as a quality indicator. In general, American colonoscopists, gastroenterologists tend to do very large volumes. They tend to get very high cecal intubation rates very quickly, and they don't fall off. So we think everybody should measure it, but it doesn't need to be measured on a long-term basis. To give you some of the details about the detection measures, we will drop the recommended age to 45 years from 50 years. And we're going to go back to the original denominator, which is, instead of screening patients, will be screening, surveillance, and diagnostic examinations, at least symptomatic examinations. So as you know, a number of papers now have shown that surveillance ADRs are the highest, screening are in the middle, diagnostic are the lowest. So if you measure the entire group, it comes out in general about the same as the screening, and has both advantages and disadvantages, but we think that that's a reasonable move. We're still going to keep the fecal tests out of the measurement, and that's primarily because there's so much variation in the United States between different types of practices in the percentage of exams that are performed for positive fecal exams. But for those that are using fecal tests a lot for both FIT and the multi-target stool DNA tests, we're going to recommend a minimum accepted threshold of 50%. The overall new recommended ADR threshold, as I said, will be 35%. We do see a lot of groups where everybody is above current recommended thresholds, and we have said that we think there's some rationale for starting to measure APC, that APC can be informative about variations in quality when everybody's ADR is above recommended level. And then we're also going to make the recommendation to increase the withdrawal time. There are multiple lines of evidence that actually detection seems to continue to increase with withdrawal times out to about 8 to 9 minutes. So it doesn't say 8 or 9, it says 8 to 9 minutes. In terms of resection, we're very interested in resection, but we think it's hard to measure, and we think we probably missed the boat with previous measures. So we're going to go for a couple of measures that we think are simple and very feasible and important. And that'll just be accurate descriptions of the morphology, location, resection methods, and then the percentage of 4 to 9 millimeter lesions that are resected with a cold smear. So hopefully just a little bit to think about in terms of some of the directions that we're going with recommendations in the US. Thank you very much.
Thank you very much. And now the Japanese perspective. I'd like to invite Dr. Masao Sekiguchi.
You tell me, I understand.
Not my music, actually. What is it? Thank you. So my name is Masao Sekiguchi, coming from National Cancer Center, Tokyo, Japan. So it's a great honor to be here. Finally, it's time for Asian countries. So, okay. Green button, okay, thank you. So the title of my presentation is Colonoscopy Quality Perspective from Outside North America. So, So in my presentation, I'm going to talk about current situation of colorectal cancer screening and colonoscopy in Asia, focusing on several Asian countries and regions. And then I'd like to discuss possibly important factors for colonoscopy quality from the Asian, particularly Japanese perspective. So let me start with this first issue. So this slide explains the population-based colorectal cancer screening in Asia, focusing on several countries and regions. So you can see Japan, South Korea, Taiwan, Singapore, Hong Kong, and Thailand. So in every country and region, FIT is used as a primary screening tool, followed by subsequent colonoscopy for positive FIT. And screening total colonoscopy is used as a primary screening examination only in the opportunistic screening in every country and region. And then how about the situation on colonoscopy for positive FIT in population-based screening in these countries? So this table includes the information on whether there are any special or strict regulations for participating endoscopies, and also you can see the issue of cost. Regarding the requirement for participating endoscopies, although usually colonoscopies are performed by gastroenterologists or surgeons, however, there are no special or strict regulations for participating endoscopies. Recently, the experience of colonoscopy has become gradually considered. And regarding the cost of issue, that in every country and region, the governmental financial support is present, and the actual cost for a colonoscopy procedure is variable according to countries. So in Japan, South Korea, and Taiwan, you can see the price is really low. On the other hand, in other countries, the price is high. And Taiwan has their very unique cost system for colonoscopy. So in Taiwan, cost for colonoscopy for positive FIT is higher than that for other colonoscopies. Very unique system. And then this slide shows the management system of colonoscopy quality in Asia. So this table includes the information on whether this country has its own guidelines on colonoscopy quality indicators. And also you can see the information about presence of nationwide standardized format of colonoscopy reports and presence of nationwide system of monitoring colonoscopy quality. And you can see the presence of nationwide feedback system of colonoscopy quality to each institution and each endoscopist. And regarding the guidelines, only Japan and Taiwan have their own guidelines on colonoscopy quality indicators. And regarding the nationwide systems, so actually only Taiwan has their own systems. So you can see that, so there is much room for improvement in Asia in total. And also you can notice that Taiwan is the most advanced country in terms of management system of colonoscopy quality. Actually, I'm from Japan, so not from Taiwan. So you can ask Professor Hamonchu the details. So in Taiwan, very briefly explaining, the population-based colorectal cancer screening has reached the level of organized screening with the excellent nationwide database systems and excellent system of monitoring and feedback of colonoscopy quality. And they set the benchmarks of colonoscopy quality in Taiwan FIT colorectal cancer screening program in their guidelines as shown in this table. And regarding cecal intubation rate and adenoma detection rate, actually the outcomes are really good now, 97.2% and 51% respectively. You can see the improvement over time. And using the nationwide database, they've also monitored the PCCRC rate. That is really fantastic, and you can see decreasing tendency. So the importance of monitoring and feedback of colonoscopy quality was emphasized by the reduced PCCRC rate. In contrast, in Japan, no nationwide endoscopy database has been incorporated in the population-based colorectal cancer screening. However, recently, Japan Gastroenterological Endoscopy Society, JGES, has tried to establish good endoscopy, nationwide endoscopy database called Japan Endoscopy Database, JED. And the society also initiated the system of certified endoscopies for screening colonoscopies and gastroscopies in 2022, including the experience of colonoscopy and upper GI endoscopy. So in order to demonstrate and introduce the current situations on colonoscopy quality in Japan, let me talk about the outcomes of J-SCOUT study. That is a multi-center observational study in Japan focusing on colonoscopy quality and outcomes using the large database. So data from individuals who had undergone colonoscopy at several institutions, several university institutions and several cancer centers and screening centers and clinic, so were analyzed. And based on the data from about 130,000 colonoscopy cases, so ADR based on pathological diagnosis was calculated to be 32.7% in Japan. However, I have to comment that this value must have been underestimated in Japan, mainly because in Japan, the Japanese guidelines allowed diminutive benign adenomas less than 5 millimeters to be left untreated, ideally using the diagnosis using image-enhanced endoscopy. So the adenoma detection rate based on pathological diagnosis must have been underestimated. Then, focusing on the data from institutions where all neoplastic polyps, including diminutive adenomas, were removed on-site during colonoscopy, we calculated the adenoma detection rate, and adenoma detection rate screening colonoscopy is 38.1%, and adenoma detection rate for colonoscopy for positive FIT was calculated to be 42.2%. So from this study, actually, we proposed the potential usefulness of endoscopic adenoma detection rate based on endoscopic diagnosis, considering the Japanese situation. So like in the setting in which diagnose and do not resect strategy or resect and discard strategy are allowed for diminutive benign adenomas, because the correct evaluation of ADL based on pathological results is difficult in that situation. Actually, we've confirmed a strong correlation between endoscopic ADL and pathological ADL in this study. So next, I'd like to discuss possibly important factors for colonoscopy quality from the Asian-Japanese perspective. So here, I'd like to emphasize as a Japanese endoscopist, so the importance of detecting this kind of flat lesions. So particularly laterally spreading lesions, LSTs, as you know, that is a different concept from sessile-related lesions. And in order to show the clinical importance of laterally spreading tumors, I'm going to briefly talk about the results of a Japan polyp study. That is a Japanese randomized controlled trial focusing on time interval of surveillance colonoscopy after baseline colonoscopies. So there are two study arms in two exam groups. So surveillance colonoscopies were performed 1 year and 3 years after baseline colonoscopy were performed. And in one exam group, only one surveillance colonoscopy was performed 3 years later than baseline colonoscopies. And in both study arms, a total of 29 advanced neoplasms were detected, and importantly, so mainly composed of non-polypoid lesions, particularly LST non-granular lesions. And also, we've continued the follow-up for JPS cohort, so using 3 annual surveillance colonoscopies. And now, at the timing of around 6-year follow-up, so a total of 77 advanced neoplasms were detected. Also, so mainly composed of non-polypoid lesions, particularly LST non-granular lesions. So based on these data and experience, we Japanese are convinced that LST non-granular lesion and flat lesions are important for PCCRC, and we believe that detection of this kind of lesion is important for increasing the improvement of the colonoscopy quality. So in this context, actually, the Japanese guidelines emphasize the importance of flat adenoma detection, and flat adenoma detection rates suggest. So however, of course, we need more discussions and more investigation. However, we feel that this could be a good quality indicator. And recently, potential usefulness of image-enhanced endoscopy and CAD-E for detection of flat adenomas, in other words, including flat adenoma detection rate, has been reported and discussed. So finally, as other potentially important factors, I briefly mentioned 2 factors. So sessile-related lesion detection rate or selected lesion detection rate may be an important factor, also in Japan, also in Asia. And also scope insertion time may be an important factor based on the findings of associations with ADL and other colonoscopy qualities observed in several studies. So let me summarize my story. So colonoscopy is widely used for colorectal cancer screening in Asia, and monitoring and feedback systems of colonoscopy quality are being developed and mature in Taiwan, leading to the improvement in the quality. However, there's much room for improvement, and detection of flat lesions, particularly LST non-granular lesions, is worthy of attention. So finally, I'd like to thank these fantastic Asian colleagues. So thanks to their help, so I can report the current situation of colorectal cancer screening and colonoscopy in Asia. So I'd like to meet all of you at end of 2024 in Seoul. Thank you for your kind attention.
I'm waiting for the music. The Ave Maria or what?
Evelien, jij bent de mooiste. Evelien, jij bent een schat.
I don't think anybody understood, so that's fine. So thank you so much, Uri. That's really kind of you. So today, after these more elaborate and very high-pitched quality discussions we've had, I would like to propose to you the idea of a new task force from our WEO CRC screening committee on colonoscopy quality assurance. And it's mostly about trying to disseminate and help other people, countries in the world about best practices on colonoscopy. So, well, in every screening program, whether you do a triage test or you do directly colonoscopy, somewhere in time there might be a colonoscopy. And we know that's the gold standard for the detection of polyps and cancer, but we also are very much aware that it's not a perfect test. There is not 100% protection for colorectal cancer, as the topic of post-colonoscopy cancers has been discussed. There's overdiagnosis and overtreatment of small polyps, a little bit less so in Japan, we just heard, but that leads to surveillance and maybe unnecessary surveillance. It's an invasive method, it's burdensome, it is risks, and also that comes down to the willingness of screenees to participate in undergoing, to adhere to the advice of the colonoscopy. And of course, it's expensive. Again, we've seen a nice example just in one continent of the world of different costs, but mainly it's a costly procedure. There's issues on capacity also discussed today, and of course also on green endoscopy or a better world. So how about that optimal colonoscopy? Well, again, I think this is an open door for all of you. We would like to detect all pre-malignant lesions, make an accurate optical diagnosis, then resect that lesion, ideally during endoscopy, if relevant, and give an advice for adequate surveillance. And that, of course, all as an acceptable and low-risk experience for the patient or the screenee in the case of screening. So looking a little bit more at Europe, because we've had the two sides of the world and discussed a little bit less, I think we were led very much by the, I think, astonishing paper from the UK, demonstrating the quality in 2004, because they were thinking of starting a bowel cancer screening program with the Guaiac FOBT, and they thought, well, let's just have a look in a few practices what's happening at colonoscopy. And they found out that in colonoscopies, the cecal intubation rate for general indications was only 57%. And this was, of course, much lower than everybody would have expected. And this raised a lot of attention. And that also led in the UK to a lot of support and effort, also by the ministry financially, to try to improve the quality of the colonoscopies in that country before starting a national screening program. And around that time, and I think it was very nice to see Doug Rex's timeline, a lot of attention has come to quality of colonoscopy. And again, if you look nowadays about all the different papers that are being published on that topic, it's incredible, and a lot has happened since then. And again, I would like to stress, when we do screen people that were not aware of the potentially having colorectal cancer, we always say in the Netherlands, we take them from the street, we give them a fit. If we then say you need a colonoscopy, of course we should deliver high quality procedures. Again, all that quality attention has led to quality indicators or performance measures, if you wish. This is the European side. This is the ESGE quality indicator schedule, and we are currently updating it as well. We just heard about the American new update. We are working on that as well, and all these domains are very familiar to you, coming from Boston Bowel Prep scores to ADRs to complication rates, all of this in this schedule. How do we know about these data? Well, that's only if we put in data in a database. And you can do that separately. After each colonoscopy, go to your computer and put in the results of your colonoscopy in a database, or you can make a structured reporting program. And I think, of course, that's much better to go. This is the one that we developed 10 years ago. We did that before we started a national screening program. We're using this kind of data input. So it's at the same time reporting as well as putting in the data to be able to monitor the program, both for quality as well as for outcomes. So it's a relatively easy way, and of course it can be much more simplified in the future. There's a lot of new perspectives on that with using AI, for example, and voice recognition, all of it. But we need these data in a certain way, and we need to decide on what type of data and how much data we need as a minimal requirement. And of course, again, we need that because we would like to be informed about the quality that we have in our practices for ourselves, because that gives us insight. We can benchmark against others, and that makes us aware and also reminds us in which areas we still can improve, and we might require extra training or any other way of trying to improve our quality. And just being aware, and I think this is a very nice simple study, helps, because this is a very easy small study of doctors not being aware they were being followed, being monitored for ADR, and after they were aware. And look, just the fact that they knew they were being monitored increased the ADR significantly. This is just what happens, and this happened also in my unit. When people found out they were having low ADRs, they said, well, how is this possible? We need to compete. I need to be better. Give me some more colonoscopies. I will show you I can do it, right? This is how it works. If we know we are being watched, we will do better. And we also know, and this was already alluded on by Doug as well, that providing feedback and improving ADRs indeed has an effect for our patients, because we have reduced PC-CRC rates then. So there's many interventions trying to improve ADR. So it's, of course, the audit and feedback, and then looking at aspects of all the different domains, like the bowel prep and the withdrawal time. And we can do additional training. And I think for myself, only then after, we can use all those extra add-on and AI and advanced imaging. But everything starts with basic quality and feedback. And this is a nice example of a quality improvement program of just a few measures being followed, and again, reduce post-colonoscopy colorectal cancer rate. So I think very nice to show you what little things can do. So should we accredit then endoscopists in general, or maybe at least for screening programs, if we propose colonoscopy ourselves to patients, maybe not at an increased risk for cancer? Well, I think it would be very logical to think about this. Can we test people for quality? Well, again, I think the English, in Europe at least, have led us the way. From that moment that they started attention on this quality issue, they started with the JAC, their Joint Advisory Group, to develop assessments of how people do their colonoscopies, just by breaking down every aspect of the colonoscopy from the beginning, from making the right indication, explaining people well about risks and what you do, to the procedure itself, about intubation, about pain in the patients, and all these things, and then, of course, also about detecting lesions, and then after. And it's very nice if you, we do this with fellows, and we now do this, and I will get back to that in our national screening program as well. It's nice to just discuss with somebody why and how he does something, and it's nice to do that in a structured way, and not just say, well, I don't like the way you do it. Why? Well, that's not going to provide any relevant and useful feedback. So to break it down in aspects like they did, I think they did a great job. And they did the same not only for colonoscopy, but also for the direct observation of polypectomy, the DOPS. And again, it goes for every detailed aspect of the polypectomy, from assessing the lesion until the resection and then the inspection of the scar. So I think it's a useful way to start discussion about quality and how you do things. So in the UK, they've then developed a curriculum, a basic curriculum for their endoscopists in general. It's very detailed. We won't go into details at all here. And then for this screening program, they've even topped it up. So they have selected a relatively small proportion of their endoscopists in the country willing to go through all the tasks to be able to be accredited as a colonoscopist for the screening program. So really highbrow, extremely well, but I also think a lot of effort. When we started in the Netherlands, our national program for FIT, we said we do want quality. We feel responsible for those that are being screened and have to undergo a colonoscopy, but we don't want to make it as highbrow. We need our endoscopists. We just want to motivate them, be aware that they're being monitored, and we hope to take them with us. So we took their example of the UK, but then made a more light version. And we discussed this already a little bit before, but our endoscopists have to be medical specialists of any type, perform at least 200 colonoscopies a year, a lifetime at least 500, which is not a lot, but just a start. And then we test them for quality parameters in 100 colonoscopies. They have to do e-learnings on all the different aspects of the screening program, as well as the details of colonoscopy. And they also do DOPS and DOPIs in a session. And this raised a lot of discussion in my country, because people, of course, felt insulted by being tested about their quality. But in the end, I think we reached a point where people realized that it was worthwhile discussing this, and they were, I mean, we've really seen a big change in 10 years in my country in quality, and about over half of our Dutch gastroenterologists are being accredited for the program, and they're yearly being monitored now and aware of their quality. So I think the quality is crucial, of course, for optimal benefit of programs and cost effectiveness. There's many tools available to then support training if you know you're not doing optimally, and to measure your competence as well. And the worldwide implementation, however, is challenging. And again, I think I had the same type of wording. It's not a one-size-fits-all, but I'm not discussing FIT now, but I'm discussing the colonoscopy. And I think I'm often being asked how to start a quality and colonoscopy program and what would be the minimal data set, and that's really how we got to this task force. So I think it would be very useful for many countries, and not for many of you that have been speaking about all the work they're doing at quality. I mean, everybody is, you know, there's lots of countries and area and regions and hospitals doing fantastic. But that's exactly what I think we need. We need all that fantastic work to try to spread it to other places where they're still struggling in how to start up quality assurance programs there. And I think as we are having all these experts in the room here and many more not being here, I think it would be very nice if we would join and try to support development of that. So Uri and Hanmo are joining me in this effort, and we invited from every continent a few people that we see as experts because they've published in the field or they're interested, but maybe there's many more. The group, of course, shouldn't be 100 people because then we can't discuss anymore easily. But anybody who's interested to join forces, we would be very happy to welcome. And the aim is, again, to disseminate the best practices worldwide to support those regional and national screening and surveillance programs to achieve high quality colonoscopy services. And we just have a few starting ideas. We will meet tomorrow. So again, if anybody is offering help and willing to join tomorrow, please let me know. And we will definitely be very happy to welcome you. We hope to inventorize what's already being done and possibly available around the world around monitoring, auditing, and training and accreditation, maybe by a survey. So even if you're not willing to join us tomorrow, you might receive the survey, and please fill it in, because anything you can help us with would be useful. We would like to discuss what would be the really minimal data set that you need for colonoscopy reporting and to be able to have a quality parameter in the future. So just for starting quality assurance programs. And then, of course, there's lots more to discuss after that. So like implementing standard reporting, monitoring, auditing, setting minimal standards, providing feedback, implementing quality improvement programs, and all of that. But that, I think, will be the next step after defining how and where to start this effort. So again, this is just the first idea. It's a very practical task force. That's why it's not an expert working group. We have an expert working group on interval cancers and on quality. This is more a support group, a discussion group, hoping to raise the awareness worldwide and to try to improve colonoscopy's quality, both in screening, but of course also in the other areas like surveillance. Thank you so much.
Thank you, Eve. We can have some minutes for questions. We can shorten the break, about 5-10 minutes, so we can discuss.
Hi, this is a great session. I have a question for Evelien and also for Doug. For the people who didn't opt in to the quality assurance, what's the reason that they haven't done that in the Netherlands? And then my question for Doug is, if it's come up before about having a certification or a certificate that the ASGE could offer that basically says that we've submitted and shown that we're meeting adequate quality metrics, just trying to think about how we can get more people to really measure and report or at least meet the minimum threshold.
Yes, so for me, yes. So why people did not start the accreditation program? I think that's mostly because many practices decided who was going to do it and who was not, because some endoscopists have other interests. And but actually we were surprised also of what happened in many practices. They said, well, we want to do it all because we think it's a quality assurance and also a way of showing that we as a whole practice deliver high quality. So actually it was a little bit the other way around. Even more people started the accreditation program because of the ambition. That's one, and then we see indeed the quality improving during time as well. So it's even more, I think, than we expected.
So with regard to the, societies, certifying people, the ASG does have a program called the Endoscopy Unit Recognition Program. And a fundamental aspect of that is that the physicians will all measure and report their ADRs. It's like anything else. First of all, there's a cost to it. There's a cost to the groups to participate. There's a cost to the ASGE to administrate it. And I think we could potentially, have a solution like that that's individually based. I don't see a reason not to do it, but I do think that there are practical issues associated with cost and administration that, in some settings are run by the federal government or the national government, which we don't have in the U.S., right? So. Again, it comes back to those groups that do it, they participate in it voluntarily, and they pay a cost for it.
Thank you.
Checked Albany, appreciate the nice talks. I feel like I'm a thin ice here because I'm a primary care physician in a group of GIs, right? So everyone turns to look at me. Doug, I'm curious because I'm thinking about this from somewhat from an equity angle, but also the thinking behind dropping withdrawal rates from the quality measures, whether that might affect the ADR in the long term.
Dropping the cecal intubation rate?
Cecal intubation rate, yeah.
Yeah, we're not dropping it. We just have a group of priority indicators. The guidelines, our recommendations from the beginning have had a really comprehensive set of recommendations, but I think very few individuals or groups are measuring all of those. So for those that are getting started in quality, the concept of priority quality indicators is that this is a group that we think are so important to outcomes that everybody should do it. So we changed the language from cecal. I agree that we have evidence. We have evidence from Ontario that if the cecal intubation rate is too low, it can result in post-colonoscopy cancers. It's true also for the ADR and the cecal intubation rate that this whole business of continuous measurement for years, what we see is that ADR rises slowly with time and then eventually kind of levels off. It very seldom drops. And cecal intubation rates, we just don't see them drop very much. So what the recommendation is that to make sure that people have adequate cecal intubation rates, but once they've demonstrated them, we don't think we need to have everybody put the effort into continuous measurement, and you could put resources into something else. For example, starting to have resection measures, which most groups are not consistently doing. So it's just a matter of trying to use common sense about how to use resources.
I guess if you give me a second, looking at Evelien's data around the rates of cecal intubation, if I'm getting that correct this time. What I wonder is that if you people stop monitoring their performance, over time there might be erosion into the performance level because they don't have a line of sight into their intubation rates.
I suppose it's always possible, yeah. But hopefully, and our recommendations have said that you should also document it by cecal photography. So you could go back in, you could do it intermittently, but in the United States also, that's something you get paid for. If you don't get into the cecum, you don't get paid for doing colonoscopy. So there's that also. I think it's going to work out.
Yeah. I think I have a similar question in a way, Doug. So congratulations on the soon-to-be publication. Like, in terms of prioritization of these rates or priority metrics, like ADR has all this cachet to it, right? It's been validated, it's associated with interval cancers, but adding other rates, like a FIT positive rate that I don't think has the same type of data supporting it for interval cancers, or sessile-serrated lesion rates, like, does the document kind of make a hierarchy out of these? Because groups probably can only do so much. And so I wonder about the value of adding in other metrics when we already have one that is validated and it's been proven that, right, people can get better with it. So I'm just wondering if you could speak to that idea.
Well, I mean, I think it's an extremely valid concern. I think the way the document is written, the idea is to keep the positive fecal test out of the ADR measurement, just so we can have some sense when we look across groups and we compare publications about how ADRs are because of the high level of variation. So we're not saying that everybody should measure a FIT ADR, for example, because many practices in the US do not have enough patients with that to even make the measurement. It's rather that if you do have a program that's relying on FIT, that you should have a different level, as you've written, Doug, in your own publication, right? So I think it all depends on the individual practice. The SSL-DR, I think this is a big deal, and we're putting it out there. I will let Evelien speak to whether she thinks the evidence is strong to start to have a measure, but we're seeing multiple studies that suggest that it adds, that high levels of SSL detection add to prevention of colorectal cancer. And so I think that we just felt there was enough accumulated evidence that we needed to make a recommendation. Any sort of serrated target is not only an additional measurement that people have to make, but it's also a more complicated measure than the ADR for reasons that we all know. But so we very heavily discussed it, and we just felt it was time to test the water. I wonder what others are thinking about this.
No, of course, you know that I will agree with you. I was just a bit disappointed. No, I think there is evidence. You've shown the seminal recent papers on the correlation, like ADR, also PSPDR as an independent variable as connected to PCCRCs. I was just a bit disappointed that you're using SSL detection rates, because I think it's rather challenging for pathologists to make that optimal diagnosis. They might miss it rather easily. And we've made a plea for using proximal serrated polyp detection rate, which I think is independent of the pathologist and has been shown to correlate very well to clinically relevant serrated polyp detection rate. So I think that would have been easier for you to use it.
I appreciate that, and you and I haven't had the chance to discuss it because we debated it quite a bit. I have, since the very beginning of the whole thing, been very concerned about the possibility of gaming things and also fairness to endoscopists. I have always felt since the very inception of the whole process that part of the beauty of the ADR was that it was a whole colon measure that utilized a pathologic diagnosis that's very easy to make. And I think the proximal thing is just a question of how well it's going to work prospectively, because it's very easy to game the section of the colon that you're in, right? I mean, I think we need to know if it's going to hold up prospectively. Because I think your data is not really prospectively collected like you're using it as a detection target.
Not prospective yet, because indeed we have not included it either yet as a quality parameter. However, I think it's all meant not to include those rectal tiny HPs, right? And I think that's, of course you can always play, but you can also play with ADR if you want. So
it's much harder to play with ADR because it's a total colon measure.
Yeah, but still after, the one and done phenomenon, after the one polyp that you detected, you stop looking. I mean,
it's hard.
We can discuss, we always need in some way, commitment of the
Yeah, we're going to get into an argument now, aren't we? It's hard to make a serrated detection target perfect. And if yours really works prospectively, maybe we'll switch. I do think that throwing the SSL thing out there also will allow groups there are going to be a lot of groups that are going to discover that they need to have a very serious discussion with their pathologist, right? Because everybody in the group is going to be less than 6%, and that's probably not right. And so we could potentially correct a lot of poor performance, by the pathologist. So, we very seriously considered it, decided that we would try this to get things started.
Well, my question is also about the SSL, because I could see it being gamed on the pathology side. In other words, a group is going to come and say, hey, you guys aren't calling SSLs, and next thing you know, pathologists are calling SSLs. So there is no doubt there's a lot of pathologic variation. I remember a paper we did a number of years ago, I think Seth Crockett was also on it, where if your pathologist was a high calling SSL, your ADR went up by 9%. I mean, there was a huge variation dependent on the pathologist.
So they shouldn't have been putting the SSLs in the ADR.
Well, that was a study measuring SSL variability. But the point is that
it's very hard to make it perfect. I agree.
No, but it's out of the GI endoscopist's hands now, See, that's the thing, because tubular adenoma was such a uniform detection mechanism, as you mentioned, it really became just a GI issue. Now you've kind of complicated. It's no longer the endoscopist's control. So that's just...
I agree with that. We want a measure of endoscopist performance to reflect the performance of the endoscopist. But I do think that putting it out there and starting to measure it will probably demonstrate a lot of things about variability in detection between members of a group, and also potentially that there are a lot of undercallers, right? I mean, we've seen studies multi-center studies where some centers don't call any SSLs. That's a problem. So I think starting to measure it, we'll probably learn a lot from that and potentially improve outcomes for some patients.
Just a real quick
Okay,
question.
sorry.
Just by way of clarification, on that last thing, the metric of 4 to 9 millimeter lesions being 90% being removed by cold snare, is the emphasis on cold snare or trying to get at removal of, the majority of the lesions?
I think the emphasis is on cold snaring. I mean, I think the evidence. I would say cold snare everything that's 10 millimeters and smaller, including the 1 to 3 millimeters. But there is still some evidence that cold forceps are okay for 1 to 3 millimeter polyps. So the idea is that don't use electrocautery and snare 4 to 9 millimeter polyps.
But what about when you have 10 diminutive hyperplastic appearing things in the rectum or something like that? I mean, is that included in that metric or?
Well, if they're 4 to 9 millimeters, yes.
Yeah,
If we're not saying whether to remove them, we're saying the fraction that are removed cold.
Okay.
Okay, well, thank you very much. We are sorry about the time, but we need to finish here. Before finishing, I want to congratulate Evelien, Linda, also Ann Sauer for having all this together every year. They need a big applause, please. Okay, we have a coffee break for 50 minutes.
There's a way to reduce cancer deaths by half in the next 25 years. What if that was a future our children, our loved ones, our world could wake up to? This is the future Exact Sciences works toward every day because we believe it's possible. We are a team of visionaries, of believers in the power of science, united by a mission to defeat cancer through earlier detection, prevention, and more informed treatment decisions. We're leading the way in getting ahead of cancer by detecting it earlier when it's more treatable. We've developed innovative tests to understand it so that when the diagnosis does arrive, the path to the best treatment is clearer. And we're working to make it all easier, using world-class services to ensure seamless experiences for providers and patients, so that people around the world can make more time for the moments that matter. Our unique approach and well-earned expertise combine science, research, and creativity to get it done. We know that we can take the fight to cancer and create a world where cancer isn't feared. And because we can, we must. We are Exact Sciences.
The fecal immunochemical test is widely used as an approach for non-invasive screening for colorectal cancer all over the world. OC Sensor Fit was introduced in Japan in 1989 as the novel fully automated fecal immunochemical test analyzer. OC Sensor has made possible the automation of stool tests, which are very complicated to handle. It has been enhancing its technologies for over 30 years. Today, OC Sensor is used in more than 45 countries. Researchers around the world have also spotlighted the clinical value of FIT and triggered innovation. As a result, more than 100 scientific papers have been published. OC Sensor Fit has been introduced in colorectal cancer screening guidelines in several countries. Along with those recommendations, OC Sensor continues to address the individual challenges of each country's screening program worldwide. In the case of a large number of participants for population-based screening, participants collect stool samples privately at home. And they send the samples to laboratories. Together with the easy-to-participate FIT, colorectal cancer screening programs become more accessible. In the case a doctor needs to decide promptly whether to perform a colonoscopy at a medical consultation, the FIT sample brought by the participants is measured with a compact FIT analyzer installed in clinical settings. With the test results, doctors can identify those most in need of urgent investigation. OC Sensor will respond to the strong desire to contribute to the early detection of colorectal cancer and solve healthcare challenges in your country.
The CentiFit 800 analyzer is a high-end system dedicated to fecal immunochemical testing, FIT, designed to provide several hundred results every hour, 1 million results every year, in full automation and with great efficiency, making this instrument the ideal solution for screening programs and for high-volume clinical labs. Up to 250 samples can be easily loaded on board on the dedicated rack handler RH150 using racks and sample trays. The samples can be loaded anytime in continuous loading, and they will be analyzed in random access seamless by the analyzer, providing up to 550 tests per hour and 4,400 tests per day. More than 20,000 doses of reagent can be stored in the refrigerated compartment on board, avoiding reloading the instrument every hour. The hands-on time is further minimized by the direct connection to distilled or deionized water supply and to the draining for the liquid waste, also decreasing the biological risks for the operators. The full automation of the system comprises, furthermore, the automatic wash solution preparation and the automatic piercing function, able to pierce the sampling tube without any manual intervention of the operator, makes the system completely safe and very hygienic for the lab professionals. The sampling pipette is equipped with a liquid sensor, able to verify the presence of the correct amount of sample, and with clot detector to ensure a correct sampling and provide accurate results. An intuitive, user-friendly management software on the large touchscreen monitor provides complete control on the assay run and over the results, calibration curves, and quality controls. The bidirectional connection to the laboratory information system provides real-time reception of the requests and delivery of the results to the screening organization or the clinicians. With the CentiFit 800 analyzer, you can achieve high throughput, reduce hands-on time, and a boost in your lab's efficiency. You're allied in the most demanding situations. The instrument is compatible with the FOB Gold line, the complete solution for the identification of occult blood in feces, and with Kalia Gold line's reagents for the quantification of fecal calprotectin, the first choice test to identify the presence of inflammation in the bowel. Sentinel Diagnostics, watching over life.
Okay, in the interest of time, I think we might start. I'm Finley McRae. I'm from
from Melbourne in Australia, and it's my pleasure to chair this session. It's session 3. It's on human behaviour and programmatic perspectives. As yet, my co-chair is not with me, so it's going to be me running the show. Thank you all for coming and sticking around till this late hour of the day. The first speaker I'll introduce in a moment, but if each of the speakers could come up and after they've given their talk and sit on the stage in anticipation of the discussion session at the end. So our first speaker is Shivan Mehta from the United States, and he'll be addressing applying principles of behavioural economics to colorectal cancer screening. Thank you, Shivan.
So thank you so much for having me today. It's a pleasure to be here and talk about a little bit of a primer on the field of behavioral economics, how we've been able to apply it to cancer screening, in particular colorectal cancer screening, but also potential opportunities to leverage this framework to apply this to other contexts in the future when it comes to behavior change. So as we've heard in this session, many sessions, if we want to think about implementing colorectal cancer screening across large populations, we have to think about multiple levels, multiple barriers at the health system / community level, clinicians and patients. And one thing that unifies engagement with clinicians and patients is that ultimately it comes down to behavior change or changing human behavior. So clinicians have to order the test or recommend it for their patients and encourage patients to get screened. And then patients and their family members actually have to follow through and be able to perform the testing and agree to participate. And so as we think about behavior change, it's relevant to appreciate that there's been a relatively new field over the course of the past few decades called the field of behavioral economics. So a couple of Nobel Prizes in economics have actually been won in this area. And what's useful about it is that it's really the intersection of psychology and economics. And what they've found is that all humans, all of us, have systematic biases or shortcuts in thinking. Many of these biases are actually adaptive. It allows us to get through our day so we don't have to think through every single decision that we make, in which case we'd be paralyzed. But importantly, it can also impede us in certain decision making. So some of these, so there's some examples from the Nudge Unit in the UK, as well as some other books that have been popularized in the literature, where they've been able to show how these types of principles can be leveraged in things like voting, retirement savings. And so a few of these biases that we know about systematically over and over again is one is present time bias. It's pretty apparent why this is important with cancer screening. You have to engage in a test today that has some cost and challenges to it for intangible benefits in the future that you may not even appreciate or realize. Importantly, behavioral economics tells us that there's actually parabolic discounting. So even shifting something from today to tomorrow has dramatic changes. Status quo bias is another one. You're much more likely to go with the default option. If it's something that you've done in the past, you're going to continue to do that. In the setting of cancer screening, many people that are unscreened have not participated, so it's not part of their habits or their behaviors, so they require a certain degree of activation energy to participate. And finally, social influence. We're influenced by what our peers are doing, but we're also influenced by people in positions of influence. So we listen to what other people say, particularly trusted sources. And marketers and companies have been leveraging these tools all the time for us every day. So I took Amtrak to come here from Philadelphia, and anytime you purchase a plane ticket or a train ticket, they want you to purchase trip insurance. And so I'm not going to get into why trip insurance is not a good thing for you. It's because it's actually a very low cost. It's only a $100 ticket, so insurance really isn't needed there. But they want you to purchase it because they make money off of it. And historically, they relied on an opt-in approach. So you'd buy it, and then you'd have to sort of click in to say yes, and most people wouldn't participate. But what they've done here is a series of sort of behavioral, very clever behavioral interventions. And you can see a bunch of different things here that I think are relevant, and you can sort of see how there's sort of bells and whistles there. One is thinking about choice architecture. So historically, it's been an opt-in approach, but what they did is they switched it to an active choice, forcing you to make a decision between either doing it or not doing it. And they added onto that something called enhanced active choice or biased active choice, where they tell you that purchasing it only costs $9, but not purchasing it could mean that you could lose $172. So that leverages something called loss aversion, which means that we dislike losses much more than we appreciate gains. In addition to that, they leverage social norms. They basically tell you that tens of thousands of your peers have purchased this already, so if everybody else is doing it, why shouldn't you? And then finally, financial incentives. And I think an important thing about financial incentives in behavioral economics is that $5 doesn't necessarily equal $5. And so what they know is that how you frame the incentive and how you provide it can actually change how people participate. So they did the same thing. They said, you lose the $172, you gain the $9. And so I think that's really important. Behavioral economics does not equal traditional. Traditional economics says if you pay somebody enough, they'll do it. Behavioral economics suggests that there's actually behavioral factors at play. And I'll talk a little bit more about that. So what our group has been trying to do, myself and colleagues have been applying behavioral economics to a lot of different health promoting areas. So it's been shown to improve outcomes in terms of activity levels, in terms of smoking cessation, medication adherence. And so this was actually a study that we did many years ago when we were first trying to introduce mailed fit to our primary care practices. So when we first said we wanted mail fit kits to everybody, as is sort of standard of care in many parts of the world, we got a lot of pushback from our PCP colleagues as well as our gastroenterologists who basically said, you can't send somebody something unless they agree to participate ahead of time. That's not really informed choice. And so we said, let's actually randomize them into an opt-in versus an opt-out approach. So everybody got either a letter or a patient portal message. In the opt-in group, they had to send back a self-addressed card or just a quick email or a patient portal message. In the opt-out group, to participate. In the opt-out group, they had to send it back if they did not want to participate, so shifting it to an opt-out approach. So just by doing that, we tripled participation from 10% to 29 percentage points. Now, as I said, mailed fit to everybody without asking them ahead of time is sort of part of what we do, but this was really relevant locally, but also kind of to frame how changing from an opt-in to an opt-out approach can be effective. But we show that that's been effective in other contexts. Another example is Hep C screening. In the Commonwealth of Pennsylvania, we're actually mandated as a health system to offer Hep C screening to all baby boomers, and now it's being expanded to the adult population to align with guidelines. And so initially they just wanted to sort of send out a message to everybody. So we said, no, let's actually randomize people to figure out which approach could be the most valuable. And so in one of the experiments, we compared just sending a standard letter where we said, you should get screened for Hep C, talk to your PCP about it. We compared that to an arm where we actually had an infectious disease doctor order hundreds of labs using bulk ordering, but making sure that the results go back to the PCP. So just by sending that lab requisition slip, it actually doubled participation from 19% to 43%. So I think what's useful there is that it has both opt-out framing, but what we call effort reduction. It reduces the effort on the patient's part to actually have to go to the PCP, get the order, go to the lab, and on the clinician's part, who's busy doing 100 other things, particularly primary care docs in these practices. The other pieces that we found is that this could be bundled together with other labs that they were getting. So when they went to get their hemoglobin A1C or their lipids checked, they would ask them, oh, do you want to get this Hep C screening test? And they said, sure. And so this is just an example of sort of this opt-in, opt-out approach. Another example was when we sent outreach to all eligible women across our health system for breast cancer screening. This was after the initial pandemic surge when women were sort of falling behind with mammogram rates. And so what we initially wanted to do is leverage this sort of trust that patients have with their PCP, but we got some resistance from the PCPs saying, we don't want you to put our name on it. So we said, let's run it as an experiment. So let's actually have half the people get it signed by the PCP, so we actually have the PCP's name there. You can see here on the left side, and the other half just from the practice. And what we found is pretty modest gain. It was a little bit underpowered, but about a 1 percentage point gain just by changing the language. And what's important there, I think, for all of our communication, and we heard this theme through a lot of the other panels, is that trust is really important for patients. So if they get something from their insurance company, they have a little bit of trust. So we've seen that when our local insurance company sends out fit kits, they get 5-10% response rate, if that. If it comes from the health system, you get a higher participation. And if it comes from the PCP, a trusted source, you get even higher participation. So this is a great example of social norms that you can leverage across a variety of different domains. And then finally, in the realm of financial incentives, as I mentioned, a $5 incentive doesn't necessarily equal a $5 incentive, which goes against a lot of things we learned in math. But one of my colleagues, Jeff Colgren, who's now in Michigan, did a study at our local VA. He found that the only financial incentive that worked when they offered it to veterans coming into an in-clinic setting for FOBT at the time was a 1 in 10 chance of $50. So that lottery incentive was the only one that worked. The other ones did not work. And that's because, that's for the same reasons that people participate in lotteries every day, even though the expected value is not very good for you to participate because most of the money goes to the government. And so it's that gamification piece. It's also the sort of, you have kind of overconfidence in actually winning the lottery when you do these things. So that worked in that context. So then actually Chaik and I did another study in the family medicine population at our clinic trying to leverage this with mailed fit outreach. And so in this case, none of the $10 incentives actually worked any better than just mailing people fit kits. What we did find is that the unconditional incentive actually had higher participation than the other ones. And that means that you send them a gift card with the fit kit. It's not conditional on them participating. That leverages what we call reciprocity, which is another social norm. If somebody does something for you, if you trust them and you have a relationship with them, you feel guilty not doing the same thing in kind. So that has worked in other contexts. What we think may have happened here is that all the people that sort of were kind of intending to participate, and that's where these types of nudges work really well. It works for people that know about something but just are sort of procrastinating. It does not work as well for people that have a significant resistance to it, or concerns or anxiety about cancer screening or things like that. You need other approaches there. And so we think that it got all those people to participate, or maybe it could have, it may have required a slightly higher amount of financial incentive. We have found in our employee population that a $100 incentive did get patients to come in to get their colonoscopy at a slightly higher rate than not offering that financial incentive. And lastly, when we think about behavioral nudges, we think about different types of communication. And so what we found from an equity perspective is that in our own practices, Black patients are less likely to enroll in the patient portal and less likely to actually participate, even if they're active enrollees in the patient portal. So it can actually exacerbate disparities and sort of make inequities worse in our population. So we convinced our privacy officers to allow us to do text messaging, which we think has a bit more sort of equitable participation, because you don't need to have a smartphone or you don't need to have Wi-Fi to do texting. And even in community health center populations, we found about 90 to 95% participation in texting. But a simple text message alone does not really work that well, based on our experience. You get text messages all the time. I got one today about someone trying to get you to do locum tenens or voting or things like that. And what we found is that you want to add a series of different behavioral interventions or behavioral tools, similar to the Amtrak example. And so here you can see a few different things we do when we send text messaging. One is that it's a series of sort of navigation with texting. Two is that it actually, you can see from name, it comes from the PCP. So the PCP is actually saying that they mailed it to you. We've added reciprocity by saying we already paid for postage, so you sort of feel like you want to send it back. We allow you to say text done if you've already participated, and it allows you to say plan, which is something that we call pre-commitment. If somebody says they're going to do something in a public setting, they're more likely to follow through on it. And so with all of those different interventions, we found that it increased participation by about 7 percentage points. And part of it is also now we're starting to link videos about how to do the fit testing, but also allow them to ask questions back and forth as well. So it's really more than just sort of simple unidirectional text messaging. It's kind of this bidirectional texting. So if we think about different principles that we can leverage, move from opt-in to opt-out framing. So switch to the default option. So screening, particularly evidence-based screening, should be the default option. People can still decide not to participate, so we're not taking away their choice. Reduce effort as much as possible. Even one click, one extra step in the process, one extra signature, one extra consent form can sometimes limit participation in cancer screening. Leverage social norms, particularly a trusted source. And then financial incentives have sort of a mixed picture. So you can use it, think about behavioral aspects of it, but also realize that there's some logistical and operational challenges to it. So as you can see, there's a variety of different ways that we can apply behavioral science and behavioral nudges to cancer screening. Another important part of this is to leverage a learning health system approach. So we've been able to run a lot of these experiments because we work in partnership with clinical operations, either at our health system or at community health centers, to be able to work with them and say, if things that are either expensive or we don't know about it or we want to understand more about it, let's actually randomize them at an individual level, in which case we can actually learn what works and what does not work, which is also just as important, and we can leverage generalizable knowledge to kind of have this sort of learning health system approach. So I'd like to thank a lot of my colleagues and research team, as well as funding sources, and you can see the disclosures here. So thank you so much for your time.
Thank you. Thank you, Meta. Shivan.
All right. Our next speaker in this session will be Martin Lajos from Mexico.
Hello, thank you so much for having me here. I think this is sort of like a 5-year report because my colleague who I worked in the first study we did for colorectal cancer screening in Mexico came to this meeting 5 years ago. So I hope to show you how we've advanced in Mexico. So, oops, okay, there you go. So, colorectal cancer is nationally the 4th leading cause of cancer mortality, but in certain areas like Mexico City or northern Mexico, it's the 1st cause of cancer mortality. So as you can see, this cancer is exerting an important burden in Mexico, and colorectal cancer screening is urgently needed. Now, what did we do? We started first looking at some initial programs that had been done in very limited settings, but it was important to report those. So the first was an experience in a tertiary care center in Mexico City, and also one in Veracruz, which is a city that's close to the Gulf, the Gulf of Mexico. And I mean, these were experiences where we basically saw that this was feasible, we could do it, but definitely the strategies that were used to ensure, for instance, fit return were strategies that would be very, very difficult to implement at a population level. So the other thing that we did was we set out to start a program in Mexico City. Again, we thought this is a city with a high burden of colorectal cancer. And we went for a low SES suburban community. And we realized that a program on colorectal cancer screening would not be possible in that setting. I mean, we identify a set of barriers that would make it very, very, very hard to do. So then that basically made us refocus our efforts. So we then changed to a more central area in Mexico City, more densely populated with slightly higher socioeconomic status. And there, working with some colleagues and with the health authorities, we co-designed a program. What we would do is we would take advantage of an existing program, which was basically these health promoters go house to house identifying children for the universal vaccination program. And so we said, well, why don't we also ask whether there is in the household someone who's eligible for colorectal cancer screening. So that's what we did. That's how we set it up. We realized that it was important to develop educational materials, both for patients and also for clinicians, and we learned a lot about how the people's ideas of what colorectal cancer was differed importantly from our expectations. But anyway, what we did was we went, as I said, we designed a program where we went household to household, trying to inviting people to come to a primary care clinic to receive the FIT. And we found that a large proportion of people, again, this is population-based, were really willing to participate in the program. A lot of them returned, more than 70% returned the fit kit to the health center. So this was actually, again, it's important that the health center was close to their homes. But COVID hit us. So this was supposed to be, we were supposed to do this in 500 individuals, and again, we ended up having a lot less participation. Now, so after that, we said, okay, so let's try to think about expanding this into more of an integrated health system. In Mexico, there's 50% of the population basically has access to integrated health systems that provide primary care through to cancer care. So we identified this health system in northern Mexico, in Monterrey. So this is a very small system. However, it's very similar to the large national Mexican Institute of Social Security. So what we did is we really wanted to understand how to recruit people within a health system. So what we did was we started out, the outreach was via email. Then for those who did not respond, we did an automated phone call and navigation. This is for them to come to the clinic to get their fit. And so we did this, again, we were just trying to understand how to do this in a health system in Mexico. So here what we found was, again, the outreach was very challenging, in terms of being able to bring people to the clinic. Around 40% of those eligible were able to do. And then, if you really think about the eligibility, around 30% return fit. However, if you look at, and I think, if you look here, you can see that if we are able to give people the fit, a large proportion of them return the fit. And this without a lot of maybe these is a group of people that had already been highly selected. However, this study really helped us understand how to implement this in a health system. And so our next step was to go and look for funding to try to do this in a much larger scale. So we recently obtained this U54 grant to establish a center to do implementation science in Mexico and Latin America. And this center will actually do a lot of capacity building. But one of the research projects, which will be size of an R01, is actually the development of a colorectal cancer program within this health system that I just described. So we really used a lot of the work that we did initially among these 300 individuals that we looked for to obtain funding to actually do this. And we've done this in partnership with UCSF, the global program, the global cancer program that's helped us a lot for the past 5 years, and more recently with the University of Texas, with this expertise in implementation science. So really, what are our research questions? We want to see how well evidence-based interventions for fit return work. So it's patient education, reminders, navigation, but also implementation strategies to support that those evidence-based interventions. We're going to try to look at both implementation outcomes, but also clinical outcomes. This is going to be our primary outcome is fit completion, but we have all these other implementation outcomes. So again, I'm not going to go through this. We're working, using all of these very useful models and frameworks that are used in implementation science, which I think are very useful for the planning and for the development for identifying, what would be useful for adapting, but also interventions, but also for identifying what would be useful implementation strategies. So in terms of what we'll be doing, this is our first aim, which is really trying to adapt what it's been shown to be effective elsewhere to the local context. So we're going to do provision of fit with patient education, telephone navigation, and patient reminders. But also, and more importantly, I think, is we're going to work on the design of implementation strategies to support these evidence-based interventions. We will also evaluate the effectiveness and implementation of these EBIs. We're going to, we design a trial, which is a hybrid trial for those who are into implementation science, and we will also, evaluate the impact of implementation strategies more in an observational sort of setting. This is, very briefly, the design of the trial and also the implementation outcomes that we'll be looking at. And importantly, we're going to look also at cost of the implementation of a program. Again, a lot of work on the costing framework, on estimation of direct costs and economic evaluation. And also, I guess one of the important things is that we're also thinking from the very beginning of how to scale this up in the country, which has almost 130 million, population of 130 million. Again, this health system that's it's sort of a lab, because it's very similar to other integrated health systems. And again, we need to start thinking about how to in resource-limited settings, how to implement these programs, thinking both in terms of the available resources and the institutional readiness, but also what the progression of a program should look like, going from prioritizing early diagnosis to getting to organized screening. So thank you very much.
Thank you.
Would you like to remain on the... Oh. Thank you very much. Terrific to hear what's happening in Mexico and where you're going. So our next presentation is from Jill Tinmouth from Canada on the Canadian colorectal screening program, comparing cancer detection and stage of diagnosis using IARC's CanScreen 5 platform.
Great. Thanks very much to the organizers for the opportunity to speak, and want to acknowledge my collaborators, in particular the members of the Canadian Screening for Colorectal Cancer Research Network, or CanScreen. Oops, I just turned it off. Okay, here we go. So the objectives in the next few minutes, I'm going to review the International Agency for Research on Cancer's CanScreen 5 initiative, and present some performance data from Canadian provincial and territorial colorectal cancer screening programs using the CanScreen framework, and then consider some explanatory factors for the observed variation in the performance. So CanScreen 5 is a world WHO initiative through IARC that was initiated in 2019. And what it does is collect, analyze, and disseminate information on cancer screening programs worldwide in a harmonized fashion. And it has a set of indicators that are both qualitative and quantitative. And the goal of this program is to improve program quality and performance, as well as to inform policymaking. So Canada, the setting for this study is a large country, but has a relatively small population of just 40 million. It is broken down, or consists of 10 provinces, largely in the south, and then 3 territories that are in the north. And while I think that most people are familiar with the fact that Canada has a universal publicly funded healthcare system, what I think people are less well aware of is that system is actually the responsibility of the provinces and the territories. So each province and territory essentially oversees its own healthcare system and is responsible for delivering healthcare to its residents. And so then by extension, I think it probably is not surprising that each province and territory manages its own unique colorectal cancer screening program. And because of this, there are differences across these programs, which creates an interesting natural experiment of a sort. So last year, at the same meeting, we presented on the Canadian programs from a qualitative perspective using the CanScreen qualitative indicators. And we did this using the essential components of organized screening programs that was developed by IARC. And as predicted, there are important differences across these programs, particularly in the area of service delivery, IT, and quality assurance. So the question that I wanted to address today is using this time the quantitative data collected through the CanScreen 5 initiative, is to look at the factors that influence cancer screening program performance, thinking about the organizational factors as defined by the IARC criteria, getting a little bit more granular and thinking about specific program design features like the related to FIT, for example, or how patients who have an abnormal FIT get to colonoscopy, and then certain population characteristics, particularly the burden of colorectal cancer. This was a project that we did in partnership with the Canadian Partnership Against Cancer, or CPAC, and we leveraged the CanScreen initiative, which consists of the collection of quantitative data using standardized forms, and which are then sort of put through a rigorous data checking process. And one of the important things, or sort of tenets, that the CanScreen 5 initiative uses is that they want to take a single cohort of individuals and follow them through the entire screening process, from the definition of the eligible population to take to the test, follow-up, and then cancer detection. So unfortunately, what actually happened when we collected data in Canada is we weren't actually able to get that single cohort. We actually had 3 distinct cohorts, and this was for the period, the goal was to collect data for the period of 2017 through 2019. 2017 through 2018. The first 2 cohorts were actually subsets of each other, but the third cohort, which was from individuals who were screened in the year prior, 2016 to 2017, and this was the cohort that was used to look at cancer detection. Nonetheless, we were able to use these data to calculate the following indicators: participation rate, positivity rate, follow-up colonoscopy rate, and cancer detection rate per 1,000 individuals screened. So here at a high level is the data on this screening program performance for the 9 provinces and territories that participated. And I think what is clear from this slide is the considerable heterogeneity and variety in terms of these data. For example, in participation, it ranged from 16% to 56%, and follow-up, as another example, ranged from 61% to 96%. And when we looked at it relative to the IARC criteria, what was clear was that these criteria, at least as sort of defined and what was measurable using the IARC criteria, these were not predictive of performance. There's still considerable variation amongst the top performers. So then we sort of took a look at these, drilling down a little bit into the more design features and thinking about the FIT kit. We thought it would be interesting to look at the positivity threshold. We've heard a lot about that today, and amongst those programs that use FIT, again, as we've heard commonly today, 5 of them use the threshold of 20 micrograms of hemoglobin per gram of stool. But what's interesting is to look at the positivity that results from that same, from that same threshold, and it ranges from 7.4% to 12.6%. So we thought that was sort of interesting, and then decided to then drill down a little bit further by looking at the types of, or the fit kit brands that were used. And it's interesting to note when you do that, that two of the programs that use the Alfreza project, the Nova Scotia and Newfoundland, were the two programs that had the highest positivity rate at that same threshold. But then when we looked at the programs that were again at that same threshold, but using the ICON product, the OC Diana, we see that there are two programs, New Brunswick and Saskatchewan, that achieves quite comparable positivity rates, around 7%, but the Yukon has a positivity rate at 11%. And we don't exactly know why this is, but one hypothesis is that Yukon is a much younger program, and so these may have a higher proportion of cancers that are prevalent cancers because it's a relatively unscreened population. So then moving on to the issue of follow-up after an abnormal screen, we looked at those rates and organized them by those provinces that offer centralized follow-up, that is, that the program essentially is helping to organize the follow-up, and those are depicted in pink, and those who rely on the individual primary care provider to organize follow-up, and those are depicted in brown. And what's interesting here is that while we would expect the centralized group to have better performance, there are some examples of underperformance here with 61%. And then conversely, when we look at those provinces that are relying on the PCP, there are examples of relatively good performance. So on this last slide, I wanted to take the opportunity to look a little more detail around the detection metric, the number of colorectal cancers detected per 1,000 screened. And this, I think, is an important outcome that most programs are going to be quite interested in. And start by looking at, just as an example, these two provinces that have very similar cancer detection rates are around 2. And I think maybe it flows logically. We might expect that it's not surprising. They have a similar threshold, they use the same kit, they have a similar positivity, and they have a similar follow-up rate, so it makes some sense that they're achieving the same outcome. But then when we look at another two provinces who again have similar threshold, use the same kit, similar positivity, but in this case they have quite a different cancer detection rate. And so one wonders, is this driven perhaps by the difference in their follow-up rates? That might be probably is contributing to this. But the other thing is the burden of disease. Newfoundland has a very high burden, the highest burden of colorectal cancer in Canada, and perhaps that's also a factor here. So in conclusion, we've sort of taken the opportunity of the structure and the design of the organized screening programs in Canada to sort of conduct, if you will, a natural experiment. And I think that it's informative. And we did so by taking a harmonized and standardized approach using the CANScreen 5 platform to looking at screening performance. And this was an important approach, I think, because it allows us to identify potential performance gaps, at least within the country. And I didn't touch on this at all, but it also will allow us to look at international comparisons. And I think one of the lessons for us is that there is considerable variation, but that this variation is likely due to a complex set of factors and is not just related to sort of how well the programs are organized, but finer details around the design of the programs and perhaps underlying population characteristics. So thank you for your attention, and I just want to acknowledge all the folks that were involved in this, including the IARC folks, the CPAC folks, and the CANScreen network, some of whom are sitting here in the audience. So thank you.
Thank you very much, Jill, for that presentation. Unfortunately, I have to be like the bearer of bad news because we started a bit late, and for the time I can only allow 2 questions. So we'd like to open the floor now for questions. Or if anybody has anything that just can't wait, it's also welcome.
Thank you very much for the presentation. I'm not sure if
maybe I'll speak very loudly. I had a question for Jill. One of the challenges we've had in Switzerland is there's a lot of opportunistic screening outside of programs. And so very often when you compare two regions, depending on how many people are getting colonoscopy outside the program, it's very different. Who is getting screened and the rates? And I was just curious if you know for the provinces and what that has an impact.
So great question, and as I said, I think I just skimmed this. Oh, repeat the question. The question was about how much is opportunistic screening sort of contributing to what we're seeing here, and does it vary across the provinces, and in which provinces is it happening? Well, I would say that there's probably opportunistic screening in every Canadian province, but it's a good question about how much is happening, and that I think is very hard to quantify. We know in Ontario that we can quantify it, and it's somewhere like measured around 10% of colonoscopies are done for an average risk indication. But that's what's reported, and we know there's gaming of the system, and that probably a proportion of symptomatic scopes are really being done for screening. So it's very, very hard to gauge. Other provinces do have less colonoscopy resource, and so I would expect that number would be lower.
Yes.
Yes, Iris Lansdorp from Erasmus Medical Center in Rotterdam. All thanks for excellent presentations. I have a question about the Mexican situation. And I'm not sure how to formulate this because I really appreciate all the work that you're doing, and I might sound critical, and I don't want to sound critical, but I just want to hear what the thoughts are for later. I was a little bit concerned with what you said when you went to this area where there was very vulnerable population, very much poverty, and I realized that, yes, probably not possible to set up a screening program there, but then if you go somewhere else and you set up a screening program there, you're going to increase the inequities in the population. So I was just wondering what the considerations are there and what the long-term vision is to make sure that you indeed have an equitable program across Mexico.
Thank you. That's a really good question. I think what we did is we realized that there we would not be able to even test the possibility of doing it. Not that we don't think that, people in very low income communities should have access to that. I completely agree with you. I mean, one of the things that we're trying to achieve is really thinking about the development of a program from the perspective of the whole population. So we're starting, but we need to start somewhere. And starting somewhere oftentimes means starting in places where some of the resources are available. We have to be careful, of course, because again, colonoscopy capacity will only be available in cities. So then we have to find that balance. What do we do? So unless we have colonoscopy capacity everywhere, then that's when we start the program, or are we going to start it or start trying to test it in areas where there is capacity? So I understand the concern. I mean, I think it's something that we all need to have in consideration. In this specific example, the reason was we realized that we were not going to learn anything by trying to work in that community.
Thanks.
Thank you very much to all the speakers. Fabulous session. Enjoyed it greatly. Thank you for our sponsors for sponsoring this part of the meeting. And we're running a bit late, but we'll meet back in about 15 minutes, close to. Oh, go straight on. Okay.
The next session will be emerging screening tests, and the chairs are David Weinberg from the USA and Su Weng Feng from Taiwan.
Okay. Good afternoon, ladies and gentlemen. We will start the session 4, emerging screen test. I am Wenfeng Xu from Taiwan. It's my great honor to co-chair with David Weinberger for this session. And the first speaker is William Grady, and the title is Normal Store and the Blood Test. How good can they get? They can get at detection advanced precancer lesions. Welcome.
All right, well, thank you very much for the invitation to talk to you today
about what's going on with molecular markers for screening for colorectal cancer. Tell you about some of the novel stool and blood-based tests. It's been a really exciting time over this last year in terms of the development of both blood-based and stool-based tests for advancing our what we can offer with the menu for colon cancer screening. So the way I've structured this talk is first I want to talk about the technology and the bioanalytes of these emerging screening tests, and we'll talk about some of the novel tests that are stool-based as well as the ones that are blood-based. We'll talk about the performance of these tests and then potential future directions. So what I want to do is just tell you a little bit about the technology. So what these tests detect different things. And so there are two stool-based tests that have come forward over the last year. One of them is based on a test that you're familiar with, which is the Cologuard test. And there's recently a high-profile publication in the New England Journal. And I see Tom Impiarelli, who's the first author on this, is here. And that's a stool-based test that's based on methylated DNA that we detect in the stool, as well as fecal hemoglobin. And the advance here is using different methylated DNA biomarkers that improve the performance of the test. There's a second one that was published last year in JAMA, and it's a test that's based on stool RNA, so not DNA. And it looks, and I've got listed here the genes that it looks at. It also includes a FIT test, and then smoking status goes into the scoring of this test. Then there was also a paper that came out in New England Journal. I had the good fortune of being one of the authors on this, looking at a ctDNA-based test. Now these are based on an AI-informed pattern of mutations, methylated DNA, and chromatin fragments. And then more recently, something that wasn't published, but there was a press release on another ctDNA-based test that uses both ctDNA and proteins. And again, as I mentioned, so one of the things that's unique about these ctDNA-based tests is that they use machine learning-based signatures, essentially, to score whether the test is positive or negative. So as I mentioned, these tests, now what are these tests? So the ctDNA-based one is called the SHIELD test, and that was developed by Guardant Health. There's another test that we just saw the results from what was called the PREEMPT trial, I'll talk about a little bit later, that was developed by another company called Freenome, and that uses ctDNA and protein. The stool RNA test is one called ColoSense, and that was developed by Geneoscopy. And then the stool methylated DNA test is the Cologuard test, and that's Exact Sciences. So first of all, what about the performance of the SHIELD test? So this is just, what I want to do is just kind of highlight the high takeaways that we can talk about later, just to give you a sense of how these perform. So the sensitivity for colorectal cancer was 83%. For the stage 1, 2, and 3, it was slightly higher at 87.5%. Again, we can talk about that later. For the advanced precancerous lesions, is around 13%, and the specificity was close to 90%, 89.6%. So what about this other test that's ctDNA and protein? The hope here was that the protein biomarkers would improve the performance of the test, particularly for the early stage cancers. And that was based on some work that had come out about this test from a trial called the AI Emerge trial, which is a case control study. And what I'm showing you in the upper right-hand corner is the performance of the test for advanced adenomas. And there was the multi-omics, the pink bar that you want to pay attention to, where the sensitivity for this in this study was 41% with a specificity of 90%. And then below that, you can see the performance for the early stage cancers was also quite good, 94 and over 91%. So there was excitement about the potential for this assay. So then they just released the results from the PREEMPT trial, which is a very large trial that was in a screening population. And there we saw the performance of 79% for the sensitivity for colorectal cancer. And you can see that by stage that breaks out, and that the performance for the stage 1s was significantly lower, around 57%. And that was set at a specificity of 91.5%, so slightly higher than what we saw in the ECLIPSE trial, which was for the SHIELD test. Again, as we saw with the SHIELD test, the advanced adenoma detection rate was lower. In this case, it was 12.5%. If they added, that was just the ctDNA component. If we add the protein component, it goes up slightly to 16.4%. And the sensitivity also for the colorectal cancer jumped up to 80.5%. Interestingly, if we look at the adenomas with high-grade dysplasia, now we see a higher sensitivity, around 29%. And that was actually also true for the Shield test, where the performance is higher for high-grade dysplasia, close to 25%. So those are the two blood-based tests and how they're performing. And now on top of that, we also have the stool-based tests. And here we saw improvements in the Cologuard test based on this new methylated DNA panel. And so here you can see the performance for this test for colorectal cancer sensitivity is 93.9% and 92.7% for the stage 1, 2, and 3s. For the advanced precancerous lesions, now we have a performance of around 43%. Here you see the high-grade dysplasia performance goes up to close to 75%, and this is at a specificity of 90.6%. So this is what, if we look at one of the figures from this paper, what you can see is in the upper right-hand corner, the performance by stage of the cancers. What's shown in the yellow bar is the performance of the multi-target methylated DNA test. So you can see quite high performance for all the stages of the cancers. And then if we look at, next to that, going over to the right, you can see the performance for the cancers and advanced precancerous lesions combined. In the proximal colon, that's the bar that's all the way to the left-hand side. And then moving over to the right, you can see comparing the precancerous lesions in the left and right. Then below that, if we go down, you can see the performance in the advanced precancerous lesions for high-grade dysplasia, again shown in the yellow bar around that 75%. But in the middle there, you can see the performance for the sessile serrated lesions. And you can see that it's quite a bit better than the FIT test. And so what I'm going to do for the sake of time is then move on to the next slide, which is now we're moving over to a different assay. This is the ColoSense assay from genioscopy, and this is based on stool RNA. And so what you can see here is what does the performance look like? Well, now we have colorectal cancers around 95% total sensitivity. And by stage, it's again fairly high. For stage 1s, they had 100%. You can see one of the things that's notable to me is that the confidence interval for the performance of these tests is quite wide. So you can see there the stage 2 cancers drops down to 83%, and for the stage 3s, it's up to 100%. For the advanced adenomas, around 46%, and high-grade dysplasia around 65%. So I think you're seeing some common themes here in terms of how the stool-based tests seem to be performing, whether it's based on stool RNA or DNA, and how the blood-based tests are working when they're predominantly based on ctDNA. And this is just what shows what the ROC curves look like for the ColoSense assay for and the panel A for colorectal cancers, and then panel B for the advanced adenomas. So, exciting. I think what we see with the stool-based test is that the current performance is more than 90% sensitivity, and the advanced adenomas is, let's say, around 45%. So I think things that we can discuss is this the limited performance of these tests? And then is this good enough? And then for the blood-based tests, what we're seeing is the current performance is for colorectal cancer over 80% on average. The Shield test slightly outperforms the test from Freenome. The advanced adenoma rate, though, seems to be in the low double-digit area. Again, is this the limit of the performance of these tests? And what are the potentials for improving things, particularly with regards to the blood-based tests and the detection of the advanced adenomas? And I think here there's a lot of work going on. And one is, are there other bioanalytes that could be looked at? One of the ones that's intriguing to me is the concept of looking at autoantibodies, which from a biological standpoint, what these are is these are antibodies that your body generates against neoantigens that are being generated by the precancerous lesions. And one of the potential advantages here from a biological standpoint, we know that antibodies are amplified once an antigen is presented. So theoretically, it could be a way to detect these early lesions, taking advantage of that. But the other possibility is improvement of our ability to capture the bioanalytes or detection. And one of the things I want to put forward that was a really exciting paper that just got published in Science. And so what the recognition is with these early lesions is they're not shedding much ctDNA into the blood. And so what this group said is, so one of the things that's important to think about is that when ctDNA is shed into the blood, it doesn't persist. It gets cleared by our bodies. And the way it gets cleared is by macrophages. And so what this group thought through is they said, well, what if we could delay that clearance process so that we could increase the amount of ctDNA that's present? And so they took two different strategies. One is that they basically blocked the ability of the macrophages to ingest and degrade the DNA, and then they did that using nanoparticles. And then they had another strategy where they actually blocked the DNA nucleases using a monoclonal antibody. So the challenge here is from a screening test is they actually have to inject these agents, and then you have to wait 1 or 2 hours, and then you can draw the blood. But what they found is that they could increase the amount of ctDNA over 10-fold. And so it was a pretty dramatic way to do this. Again, I'm just kind of throwing out that as one possibility, but it's interesting that this might be one step forward to take the technologies we have and actually improve the performance for screening tests. So lots of interesting ways of getting at this. And so with that, thanks for your attention, and I'll finish up and we can turn over to the next speaker.
Thank you, Bill. Next are 2 people, I think. I'm not sure what order they're going to go in. One representing the Erasmus group and one from Stanford, Drs. Van den Pudelaar and Manolithara, who will be discussing liquid biopsy for colorectal cancer screening, modeling to guide practice. Who's going first?
Welcome. My name is Rosita from the Erasmus Medical Center, and today I will present on the cost effectiveness of blood-based colorectal cancer screening tests. And I also want to acknowledge my colleague Pedro, who also led part of the analysis. So in 2021, CMS issued a coverage decision stating that triennial blood-based screening will be covered in average risk individuals aged 50 to 85 if a blood test has a minimum sensitivity of 74% and a specificity of at least 90%. And note here that the coverage decision does not specify a minimum sensitivity for adenomas. So although there was sufficient evidence for this decision, we wanted to investigate whether blood-based tests that meet these criteria are also cost-effective for colorectal cancer screening. And to answer this question, we used the 3 SysNet models to simulate and compare different screening strategies. And these models work as follows. So they all simulate colorectal cancer through the adenoma-carcinoma sequence. So individuals begin lesion-free, and as they age, they can develop 1 or more adenomas that can grow in size and eventually may also develop in preclinical and clinical cancer. They can also die of cancer, but they can also die of other causes at each state. And with screening, we can interfere in 2 ways. So we can detect cancer earlier, but we can also remove adenomas by screening and preventing cancer. And we can compare the natural histories with and without screening to obtain the effect of screening. So after we simulated all screening strategies, we determined the costs and effects. And the effects are expressed in quality-adjusted life years gained, which are the life years gained from screening minus the disutility from screening and from having cancer. And we included all costs related to screening, follow-up, surveillance, and treatment. And with these costs and effects, we can compute the incremental cost-effectiveness ratio, which divides the incremental costs by the additional benefits gained from screening. And if this incremental cost-effectiveness ratio is below $100,000, we consider it cost-effective. So which strategies did we simulate? So first is a blood test that meets the CMS coverage criteria. And because the CMS coverage criteria did not specify a minimum sensitivity for adenomas, we assumed that they were only detected by chance. And we assumed that this sensitivity was equal to the positivity rate in individuals without adenomas or cancer. We also changed the screening ages to 45 to 75, which is in line with the current recommended screening ages in the US. And besides this hypothetical test, we also considered 2 existing blood tests, the EpiProColon and the Shield test. And here in red and green, you can see how they compare to the CMS coverage criteria. So the EpiProColon test performs slightly worse, and the Shield test is slightly better. We compared the blood-based screening strategies to no screening, to FIT screening, and colonoscopy screening. And again, we can briefly compare the test performance characteristics to the blood-based test that meets the CMS criteria. Let's move on to the results. So here in pink, we have the 3 comparator strategies, and in green, we have the blood-based screening strategies. And we display the colorectal cancer cases and deaths on the left, and the number of tests and colonoscopies on the right. And here we already have a first indication of the effectiveness of blood-based tests. As you can see, they can decrease incidence and mortality compared to no screening, but not compared to FIT and colonoscopy. Although the absolute numbers were slightly different across models, we see that the result is similar across models. So now let's add the costs of blood-based tests. So here we have a typical cost-effectiveness plot with the cost on the x-axis and the QALYs gained on the y-axis. And we displayed here no screening and the blood test with the CMS coverage criteria. And we see that this has an ICER of 44,000 per QALY gained. So this is below the willingness to pay threshold that we set. So we can conclude that it's cost-effective compared to no screening. If we add the other 2 blood-based tests to the figure, we see that they, although the sensitivity and specificity were slightly different, the result is very similar. So it can be beneficial in otherwise unscreened individuals, but what if people move from FIT or colonoscopy to blood tests? So now we have added FIT and colonoscopy to the figure as well. And if we move from FIT and colonoscopy to blood tests, we see that we actually lose QALYs and we increase costs. So in this case, blood tests are actually dominated by FIT and colonoscopy. And again, we see a similar pattern across all 3 models. So with current performance characteristics, blood tests are not cost-effective, but what if they improve in the future? Under what conditions would they actually be cost-effective? So to investigate this, we did a threshold analysis, and here we varied the screening interval of a blood test, the sensitivity for colorectal cancer, and advanced adenomas, and we also varied the costs. And this resulted in 900 different combinations. So this graph is very full, but I will walk you through it. So in the 3 colors, we have the different test interval of blood tests. So in orange, we have the 1-year interval, purple, the 2-year interval, and in black, the 3-year interval. And the dashed and the dotted line represent different sensitivities to colorectal cancer screening. And the horizontal lines are the effectiveness threshold of colonoscopy and FIT. So whenever a blood test crosses this horizontal line, it means that they are as effective as FIT and colonoscopy. So if we take one crossing, we see that this is an annual blood test, and it has to have sensitivity to advanced adenomas of at least 20%, and has to have a sensitivity for colorectal cancer of at least 74%. But if we move to a biannual screening test, we see that we actually have to increase the sensitivity to advanced adenomas to 45%, and colorectal cancer sensitivity to 92%. And we can also see that a blood test that is performed every 3 years will never reach the effectiveness threshold of colonoscopy and FIT. And again, the results were fairly similar across models. So again, let's add the costs to this figure. So now the colors, the different colors represent the different sensitivities to advanced adenomas. And every dot on the blood-based line is a different screening interval. And again, we have the cost on the x-axis and the qualities gained on the y-axis. And in this figure, we didn't change the cost yet, so it still cost $500. And we can clearly see that the lines, the efficiency frontiers of FIT and colonoscopy are far away from the blood-based test. But if we reduce the cost of blood-based screening with 50%, we see that the blood-based screening test moved from the gray lines to the colored lines, but we're still not close to the frontier. So we need to reduce cost even more. And in fact, only 12 out of the 900 combinations that we considered was a blood test cost-effective. And in all these combinations, we needed a 1-year interval and sensitivity to advanced adenomas of at least 40%, and the test could only cost $25 to $50. So to conclude, in an otherwise unscreened population, blood tests could be beneficial, although individuals that may have declined the colonoscopy need to understand the need of a possible colonoscopy in case their test is positive. And compared to FIT and colonoscopy, we saw that it was more costly and less effective. So switching could actually worsen patient outcomes. And this result is mainly driven by the inability to detect advanced adenomas and the high costs. And this was also confirmed in our threshold analysis, in which we showed that to be equal in cost effectiveness to FIT and colonoscopy, we needed a sensitivity to advanced adenomas of at least 40%, and we needed a 94% reduction in costs. Thank you.
Thank you for your presentation. And the next speaker is Ajisa Minalisara. She will report the result from the Stanford.
Thank you, Dr. Su. I'm presenting this report on blood-based biomarkers for colorectal cancer screening on behalf of my esteemed colleagues. Most of them are present here today. First, I'll present the modeling that we did for AGA workshop and the publication in gastroenterology. And then I'll present the modeling we did since the 2 recent publications on blood DNA test and next generation stool DNA test. We named our model MOSAIC, Model of Screening and Surveillance for Colorectal Cancer. This is a refined version of our previously published model that was validated against 4 screening RCTs. Comprehensive upgrades included calibration to contemporary polyp prevalence and validation to metachronous CRC incidence and deaths after colonoscopy. This is the natural history module that reproduces age-specific incidence and prevalence of polyps and CRC by stage in the US without screening. People transition between these health states in 1-year cycles and are followed until age 100 years or death. Without screening, the CRC is diagnosed only after symptoms develop. Screening from age 45 to 75 years and post-polypectomy surveillance through age 80 are superimposed onto this natural history module. Our model has been validated against 4 RCTs of FOBT and sigmoidoscopy and 4 post-colonoscopy cohorts. The main message of the figures on the left is that the model's predictions in red match very closely with the 4 trials, ITT, and per protocol results. Illustrated on the right is how MOSAIC's predictions of post-colonoscopy CRC match the results from Click et al., depending on baseline findings of advanced adenoma versus non-advanced adenoma or normal colonoscopy. Coming to our current analysis, CMS has decided that they will cover a blood-based CRC screening test every 3 years if it has at least 74% sensitivity and at least 90% specificity. From now on, for the sake of time, I'm going to call a blood-based test that matches these minimum criteria, CMS minimum. Results of our modeling are now available in press. I'll walk you through the highlights now. These are the clinical outcomes by screening strategy. On the left are CRC cases, and the right bars are CRC deaths. Black bars represent no screening. Yellow ones are for colonoscopy every 10 years. The red ones are for annual FIT. Tan ones for FIT once every 2 years. And the blue ones for stool DNA test once every 3 years. We see that these established screening strategies substantially decrease CRC cases and deaths compared to no screening. This is CMS minimum offered every 3 years. It is less effective than colonoscopy, FIT, and stool DNA. If the CMS minimum test is offered every year, its effectiveness approaches to that of stool DNAs. This is Garden Shield, offered every 3 years, with a CRC sensitivity of 83%, APL sensitivity of 13%. It is less effective than colonoscopy, FIT, and stool DNA. When we look at methylated septin-9 test offered every 3 years, it is more effective than CMS minimum and Garden Shield every 3 years. With a CRC sensitivity of only 64%, how could that be? That is explained by the fact that it has lower specificity that leads to more colonoscopies and incidental detection of APLs. Coming to participation, CMS minimum test offered every 3 years matches annual FITS results for CRC prevention at 1.8-fold participation, CRC death prevention at 1.5-fold participation, and QALYs gain per person at 1.4-fold participation. The most important message from these initial analysis is that if the CMS minimum test increases the CRC screening rate by capturing the unscreened, the always refuses to stool test or colonoscopy, it improves outcomes and costs $28,500 per QALY gained, assuming same test cost as stool DNA. But if the CMS minimum test substitutes for the effective stool test or colonoscopy, it leads to worst outcomes. This is to show the impact of sensitivity for advanced precancerous lesion of a blood-based test. X-axis is sensitivity for APL of a blood-based test. Y-axis is QALYs gained per person or effectiveness. Line with yellow dots is effectiveness of colonoscopy once every 10 years. Line with red dots is effectiveness of annual FIT. The curves with blue-green dots are blood-based tests performed every 3 years with increasing CRC sensitivity. As you see, increasing CRC sensitivity has modest impact. However, increasing APL sensitivity has a large impact on effectiveness. So, sensitivity for advanced precancerous lesion is critical. A paradigm-changing blood test could have, for instance, CRC sensitivity of 90%, APL sensitivity of 70 to 80%, positivity rate of 10% among people with normal colon, offered every 3 years, match the benefits seen with the clinical benefits seen with FIT or colonoscopy. And to be cost-effective compared to annual FIT, the test would need to cost $120 to $140 or less. Now let's turn our attention to the 2 recent publications in the New England Journal of Medicine, the first one being the blood DNA test, second one being on next generation stool DNA test. Blood DNA test has CRC sensitivity of 83%, APL sensitivity of 13%, specificity close to 90%. Next generation stool DNA test has a CRC sensitivity of 94%, APL sensitivity of 43%, specificity of 93%. FIT performance in this study was slightly worse than in the initial stool DNA study from 2014, with a CRC sensitivity of 67%. We did probabilistic analysis incorporating these new test characteristics, And these analyses account for decreases in specificity as age increases and increases in APL detection as age increases, reflect uncertainty in test performance characteristics, and compare to fit with reduced CRC sensitivity. Here are Mosaic's predictions, assuming perfect participation. The blood DNA test shown by the red bars with relative risks of 0.58 for CRC incidence and 0.44 for CRC deaths. The impact was progressively greater with next generation stool DNA in tan, fit in brown, and the greatest predicted impact with colonoscopy in green. Now let's see what happens with imperfect participation. Notice the bars of screening strategies grow taller and get closer to the black bars that reflect no screening. These results reflect an illustrative scenario in which the blood test had the best per round participation rate of 75%, and the assumed participation rate for stool DNA was lower at 60%, and for FIT and colonoscopy, it was 50%. And we assumed a 60% follow-up colonoscopy rate after any abnormal tests based on latest US data. And as expected, participation is a key driver of effectiveness. In this particular scenario, the differences in participation were not enough for the blood test in red to match the FIT in brown. In summary, a blood test that just meets the CMS minimum thresholds probably is highly effective and cost-effective in persons who refuse stool tests or colonoscopy. However, substituting such a test every 3 years for stool tests or colonoscopy is not a good idea. At present, Guard & Shield resembles this test. A key message from our analysis is that APL sensitivity should be a priority for test developers. As expected, participation and test costs are key variables. Thank you very much.
Well, I predict our first 3 presentations will provoke just a little bit of discussion, so we should save some time, but batting cleanup, as it were, is Dave Lieberman, everyone's reward for staying for a spectacular plenary session. It's good to have a last speaker as
Thank you. I'm actually very nervous because I know I'm the last speaker keeping you from your evening plans. So I thought, let's see, green, that I would just tell you a story. And stories begin with, once upon a time, I found a lamp, I rubbed it, and of course a genie appeared. And what the genie said was, "Hi there, I am a 1-wish, not a 3-wish, a 1-wish genie, what would you like to have?" So I thought about this and I said, well, how about a blood test to screen for colon cancer? Everyone would rush to get screened, lives would be saved. So the genie said, I can do it, but it might not be perfect. So I said, well, it's okay. We can let our decision modelers, Rosita and Ajitha, kind of figure this thing out, which we just heard some great presentations from them. So I said, okay. But the genie said, it might open up a Pandora's box. And that's a part of another story. And so what would be in that Pandora's box? Would adherence really be better than FIT or colonoscopy with a blood test? Would the test be better than no screening? Would the test be at least as good as current screening tests? And would it improve or worsen disparities in colon cancer screening? So those are some of the questions that this Pandora's box opened. And so we thought, well, let's have an AGA workshop to discuss this. And so we assembled an expert multidisciplinary panel, some of whom are here today. And we invited the modeling groups that you just heard from, the CISNET group and the group from Stanford, to do some modeling. And the charge to the modeling groups was, as you just heard, to use the CMS minimum criteria to compare a theoretical blood test at that point with no screening, and then to compare it with currently recommended tests, including FIT, multi-targeted stool DNA, and colonoscopy, with the endpoints of note being colon cancer mortality, incidence, quality-adjusted life years gained, and cost effectiveness. So you've heard about the minimum criteria set by the CMS. So these are the two studies that you've already seen some data from. The Garden study I won't go into because you just saw the data, but a key point I think from this study was that it identified the sensitivity for stage 1 cancer was 55%, and the advanced adenoma detection rate was 13.2%. Very close was the Preempt study, which has not yet been published, so this is a press release showing high-grade dysplasia detection of 29%, stage 1, 57%, very close to the other test, and advanced adenoma detection rate of 12%, both of them hitting that 90% specificity threshold. So those are the tests. And I think it points out that maybe there are some potential biologic limitations of a blood test. So a stool-based test theoretically could detect advanced adenomas or early cancers because cells are dying and appearing in stool and can be detected in stool samples. But it may be trickier for them to show up in a blood test. And as Bill Grady pointed out, perhaps there may be ways to amplify the detection of circulating free DNA, but if it's not there at all, then it may be difficult to detect. And so he mentioned the possibility of autoantibodies and other factors that might be helpful for diagnosis. So it's not a hopeless endeavor, but I think the fact that the two studies that have come out so far show significant limitations for detection of early cancer and advanced adenomas is of some concern. So the consensus statements that emerged from our AGA workshop were, first of all, the goal was to compare a new test with no screening. And based on the modeling that you just saw, it is superior to no screening at all. And again, just to highlight briefly, this is from the Stanford model showing the difference between no screening in black and screening with the CMS minimum criteria, showing it to be superior both in incidence and mortality. And likewise, in the 3 CISNET models, we see the same thing. So the second aim of this was to determine a comparison between the existing tests and this new test, with the goal that this new test should be as effective or better than current screening to be implemented. And what the modeling showed, as you've seen, is that a test meeting the CMS criteria is less effective than the current screening, despite a wide range of assumptions about adherence. And so this is, again, you've seen some of this data showing where a new test would fit compared to the existing tests, and it is not as good as the existing tests, and likewise in the CISNET models. So the next thing we asked and the modelers to do was to say, what would it take for a blood test to be as effective as current screening tests? So one question was related to adherence. Could we get adherence? Would adherence with a blood test, could it be so great that it would offset some of the other disadvantages of the blood test? And what the models show is that the adherence would have to be extraordinarily high in order to be able to be equivalent to the blood test. So this is one of them from the Stanford model from Yuri Ladabaum's group, showing that if the overall participation for FIT was 50%, then the adherence for the blood test would have to be 90% to have a similar number of cases prevented, and about 74% for deaths prevented. So it suggests that the rate would have to be extremely high, and if the FIT rate were to achieve 60%, then it's really not even possible. Okay, so adherence alone isn't going to do it. And this is from the CISNET model showing roughly the same thing, that a blood test would have to be at about 100% and still would not quite reach the level of quality-adjusted life years gained compared to a FIT that was achievable at 60% adherence. So that was one element that we asked. The second was that we asked whether if the adenoma detection rate could be higher than this 12 to 13% that has been published, would that make a difference? And again, the models both show the same thing, that if you could get the adenoma, the advanced adenoma detection into the 40 to 50% range, then you approach the same level that you can achieve with FIT and colonoscopy. The last variable that we looked at was the test interval. So the assumption was that this test would be performed at 3 years. That was an assumption not by us, but by CMS when they came up with their criteria. So we asked, well, what if we took a look at this at different intervals? And it's interesting that when you look at the 1 year interval, which is highlighted with the red arrows there, you can see that the number of cases per 100,000 now begins to approach the same level as FIT, okay? And this is another way of showing it so that it's actually, up in the top there is the annual blood test, and then you see either a biannual FIT or an annual FIT. And they're very, very close in terms of quality-adjusted life years saved for that. Now, big difference in cost, as you can see. And as has been pointed out by both Rosita and Ajitha, cost is going to be a big factor here, and the cost would have to come way down in order for it to be equal in cost. But at least in terms of effectiveness, it can get there with an annual test. So the last question we posed, we really don't know the answer to. And that is, would a new test worsen or improve disparities? And you could imagine different ways in which it might do one or the other. But we were concerned that a new test could worsen existing disparities due to issues related to access, to the cost, to insufficient navigation, and also, as was pointed out in one of the sessions earlier today, lack of trust in the healthcare system. And here we're talking about some genetic information, and so this may be a sensitive issue for some individuals. And so that could be an issue that could actually worsen disparities. So the high-level 30,000-foot conclusions from our meeting were that we do have evidence, which I didn't show, that adherence would probably be higher with a blood test than with the existing current screening tests. Compared to no screening, the CMS minimum criteria has better outcomes and can be recommended to those who decline other tests. That compared to current tests, the CMS minimum criteria has inferior outcomes, is more costly across a wide range of assumptions, and cannot be recommended to replace other tests. And finally, to achieve comparable clinical outcomes to the current tests, adherence would have to be very high, 80 to 90%. Advanced adenoma detection would have to be 30 to 50%. And frequency of testing may need to be annual. So, what will the next story be? Will it be Pandora's box, or will it be the Holy Grail? Stay tuned. Thank you.
Thank you, David. Taking a page from Dr. Blake's book, 2 questions, and then Dr. Dekker would like to make a couple of closing comments.
So, David, just curious about the assumption of the adenoma, what you would need for advanced adenoma detection rate. Because, as we all know, so-called advanced adenomas by current definitions are very heterogeneous. And I would submit a 1 centimeter tubular adenoma is probably not going to have, well, I know it's not going to have the same risk as a large adenoma with high-grade dysplasia. And so are you putting those on the box? Where's that data actually coming from when you're talking about advanced adenoma rate having to be at that level?
Well, first of all, I just want to say that the CMS criteria didn't specify anything about advanced adenomas. And so we asked our modelers to come up with a plan based on the current definitions of advanced adenomas, which are tubular adenomas greater than 1 centimeter with villous, either with villous histology or high-grade dysplasia.
Right, but if you took out the low-risk, quote, advanced adenomas by those definitions and went to adenomas with high-grade dysplasia, some of these tests can, well, not the blood test, but the stool test can get up in that range, so we'll have to see. But I'm just making the point that it's a heterogeneous definition, as is apples and oranges with some of those tests, because if you look at, methylated septa-9, the stage performance is not the same as the newer tests.
Yep.
And even when some studies group 1, 2, and 3, 3A and 3B colon cancer are quite different in their outcomes and behaviors. So we really got to get more granular in how we're looking at the data.
Yeah, I don't disagree. I mean, I think the advanced adenoma group is a heterogeneous group, to be certain. This was an effort to try to use the information we have right now to perform some modeling and predict what would need to be done to achieve equivalence for a blood test with the existing tests.
So I have basically comments, and Samir is the person who's going to ask the questions, if you can try that. So great presentation, and Bill, I appreciate your points. And actually my question to you is that from a practical perspective, how feasible would it be to actually interrupt that macrophage activity to be able to detect the signals in the blood? Just a food for thought. But the one point that I think is really important for us to consider in these comparisons, and I'm a lover of models, and those who know me well, is that the disease spectrum that's detected by one test is different than the next test. So do we model, for instance, comparably the number detection, stage 1, stage 2, stage 3, 4, and so forth? Because you can get to the same point of sensitivity by getting different disease stages. I think that's really important for us to consider, to not sort of think about fit versus another test on the basis of just sensitivity alone. Disparities in clinical attendance is sort of a beef of mine, a pet peeve, because the issue is not so much for those who go to see a doctor. There's a problem there, no doubt about it, but the problem there mostly is because people have structural and social barriers that prevent them getting into the clinic. If you take that into consideration, then blood tests are not going to address the disparity gap. Samir has a question, right?
So I really appreciate this session. I have a conflict of interest because I participated in the ctDNA paper. So I think we've had some questions answered, which are that the current blood, the ctDNA and a CMS threshold should not systematically replace currently available screening tests, and that they should not systematically substitute for other tests. I think one of the questions I have is what's going to be the greater harm if we make the blood test available? Is it going to be substitution by displacement, or is it going to be that there will be the opportunity to get all these people who haven't been screened to participate in colon cancer screening? And I'll just add, we haven't seen much substitution with the current tests that have come on the market. So I'm just curious what you all think about that, and sort of what you see as the bigger problem, really, that the unscreened piece or the substitution.
Yeah, I think if they're so easily performed, like with routine other tests, I think they may be substituted by FIT or colonoscopy. And I think there's also a lot of marketing right now for these blood tests. And I think people are really sensitive to marketing campaigns. So I don't think we can really rule out the substitution. But yeah, I'm also not sure.
I'm optimistic that the Coronado paper that we have seen in Kaiser data that there is improvement in participation rate when they were not taking any test. There's an improvement in participation with blood test. So I think it will be a useful test.
I'll just add one quick comment. I mean, I think there is going to be an issue with substitution. I think that's what you're implying, Samir. And I think it's going to create a burden, I think, for primary care physicians if they choose to take it on, to try to explain why one test might be better than another test for that individual. The other thing I worry about a little bit is if blood tests are used only for patients that decline everything else, including colonoscopy, will they be willing to have a colonoscopy for a positive test? And we don't know the full answer to that, but the hope would be that they could be convinced to do that. And that would have to be part of the informed decision making that takes place with the primary care provider.
Thank you. I'll just clarify with the substitution. I think it's more possible that the primary care docs will continue to strongly recommend colonoscopy, at least in the United States. And so I guess I'm a little bit less worried, but I could be being naive too.
I have a question about the modeling studies. In the papers, the sensitivity from the blood test was about 80 to 83%. And that was like an aggregated sensitivity. But for stage-specific sensitivity, it was different. 2, 3, and 4 was 100% for the SHIELD study. So I'm curious if that was modeled specifically, that it was lower for stage 1, but high for stage 2 and 3 and 4. And if it was modeled every year, if you can prevent all of stage 2 and 3 and 4 cancers, will you actually have really great CRC death outcomes?
We looked at the stage-specific sensitivities, and we didn't see much difference in the results, the clinical benefits. And we also did sampling size power calculations to see how much difference we would find between early and late stage cancers. That would be, the sample size would be prohibitively high, 30,000 to more than 30,000 to 70,000 people. So, fortunately, based on the modeling, it didn't show much difference by using stage-specific sensitivities. Thank you.
Dr. Robertson, you are the last question.
It better be good. Well, I have a disclosure, right? Like, I'm a big fit enthusiast, and I think my license plate is Mr. Fit. But so that's quite a disclosure. But David, you said something about it's hard to beat fit because if you just have fit adherence at 50%. You got to have really high blood testing adherence, and if fit adherence gets to 60%, it's impossible. But in opportunistic screening in the United States, I don't suspect we're anywhere close to those levels of, if you offered 10 fits over 10 years, people would do that. So I suspect, right, I think we should realize, at least vis-a-vis fit, that opportunistic screening with fit, even programmatic screening, we know what the numbers are and confirm, it's hard to accomplish 50 and 60% rates of adherence over 10 consecutive years, which is what the models, I think, are assuming. Am I correct?
Yes. Yes, that's correct. Opportunistic, we saw that it gets to 30% adherence mostly. With organized, it could be better, and we see that there is a benefit in that sense.
So I just wonder if that opens the door a little bit for some of these opportunistic tests. That's part of their advantage, that they do it less frequently.
Yes, that's true. I agree. Thank you.
Okay. Let me thank the speakers and the panel. And Evelien has something to say to all of us.
Wow. Well, just a few last words. First of all, I would like to thank Uri. Where are you? I just saw you. Yeah. Thanks so much. I mean, I think you did a great job. We did a great job, but
a lot of honor to you, with a lot of timely topics, I think. We had a great day. I hope you almost enjoyed it as much as I did. I think especially all the discussions, I think, is one of the greatest things of this meeting. And so thanks a lot to all your work. Second, I thank very much all the attendees and also those not participating now live, but maybe online or another time, because as you know, we always encourage you to submit topics and ideas for sessions and for these meetings, and that's really how we build the program. So don't forget to keep doing that. Next year, be in time. Let us know what you think are great topics for discussion, presenters, whatever you like to tell us. We try to accommodate and build a nice program again. And also, we would like you to bring up some young colleagues, because especially as chairs, I would like to make more combinations with young colleagues that are starting their career. And for us, it's rather difficult to find those in the list of attendees. Also because some people sign up relatively late. So maybe you can make us aware of new stars to come. And if you think you're a star yourself coming up, please tell us. Because I think it would be very nice to have a combination of all those great stars that we have and also having some younger stars amongst us. So please let us know. So I think a last few comments on the next coming up sessions. We will be having a session, of course, as always, a full day aligned to UEG Week. It's in Vienna this year in October. So on the Friday again, we have a great meeting. UEG Week is nice, but also WEO. So maybe it's a good reason for you to attend it. The program tends to be a bit different from, this is more an American style meeting. So I think it's nice to also attend that. There won't be too much overlap. I think it's always will be interesting. And we intend to, again, record the plenary session of the afternoon if we are watched enough, because it's quite costly, so it has to be of any additive value. Then we have APDW in November on Bali. Maybe another nice place to go for you. I think it is. And then, of course, then it will be next DDW. I would like to finish off with thanking the sponsors. We had great support. We always need more support. As I said in the beginning, it's getting more and more difficult to organize those kind of meetings. So we are very grateful to the sponsors that were willing to do so. ICANN, Exact Science, Polymetco, Sentinel, and Alfresa. So thanks a lot, and I think they need a great applause. Also here, anybody signing up as a star company, please let us know. Aljana and Michel, but especially Aljana, taking care of the whole committee and especially these meetings, does a fantastic job. And thanks so much, Aljana. Thanks so much. And then last but not least, I will also try to keep you a little bit from your evening events, because we have drinks. And it's always very difficult for me to convince Aljana and Michel that we really need drinks after a long day. We can't go home directly. So there is drinks, so please join us. It will be in the same room as where we had lunch. So on your way out, take a left before you leave, and let's have at least one drink all together. Thanks so much, and see you soon.